Good evening, Vishal. Over to you.
Very good evening, sir. Very good evening to you all. Should we begin, ma'am, with your due permission, Dr. Indrani, ma'am?
Yeah, I think so. We can start.
Very good evening to all. Very good evening to the patrons, Dr. Tej K. Kaul, sir, to Dr. S.P. Sharma, sir, President Dr. Indrani, ma'am, Vice President Dr. Naveen Malhotra, sir, Honorable Major General Dr. Navdeep Sethi, sir, and all the GC members. Today, on this day, the foundation day of our organization, RSSCP, I welcome all on the board. I welcome you all on the board. It has been said and believed since long that for any great work to be done, it is important to have the right foundation. It actually forms a platform on which the future stands. The foundation day of any organization is the day from which the institute started its journey. Therefore, obvious that the day is special and needs celebration in due manner. Foundation Day is also the day when the past, present, and future of the institution comes together, taking vows to uplift the institute to the greatest possible heights and dimensions. I should not miss thanking the founders of this great institution who had a vision of imparting high quality academics. Special thanks also go out to all the teachers who have been constantly endeavoring to impart the right academics. On our foundation day, we take the pledge to work earnestly for the growth and development of the organization from all aspects. Now, I would like to call upon our President, Dr. Indrani ma'am, to say a few words. Dr. Indrani ma'am, please.
Thank you, Vishal. Good evening, respected patron, Dr. Tej Kaul, President-elect, Dr. Naveen Malhotra, Vice President, Dr. Anju Grewal, Secretary, Dr. Vishal Singla, GC members, past presidents, and editors of JOACP. Today is the foundation day of RSACP. The day RSACP started its journey way back on the 24th of July, 1984. It's about 39 years since. And looking back in time, reflecting the beginnings to the time now, which reflects a highly academic society which has grown to what it is today. This would not be possible without the vision, support, and blessings of our illustrious founders. My humble obeisance to all of them who have contributed to the overall development and growth of this great society. Without any doubt, JOACP, our journal, is the icing of the cake, and the success is purely due to the hard work of all our editors. Thank you all very much. You all know that we had very challenging times during the last 2 years. When lemon is thrown to you, make lemonade. That's what we did. We have since had webinar series every fortnightly without fail, and this has helped us spread our wings. I take this opportunity to welcome all of you to this. On this auspicious day, I seek sincere blessings and wishes from all of you, all our teachers, seniors, and well-wishers, so that we take RSACP to new heights. Thank you all once again on our Foundation Day for making this journey successful. Long live RSACP.
Thank you very much, ma'am. Now, I would like to call upon our patron, Dr. Tej K. Kaul, sir. Dr. Tej K. Kaul, sir, please.
Good evening, everybody, and a warm welcome to this event of celebrating the Founders Day of RSSCP. A great day for all the life members of RSSCP and the anesthesiologists the world over. We must put on record the efforts and the hard work done by the founders. Particularly, I can recall the names of a few, although it doesn't complete the list, like Colonel Tandon, Brigadier Suri, Brigadier Baljeetam Singh, and all other past presidents, secretaries, editors who have worked hard to bring RSSCP to the present level. I am sure the present GC members, the governing council with Dr. Indrani, Dr. Vishal at the helm of affairs is definitely going to take RSSCP to great heights. I extend my best wishes and felicitations for this occasion. Long live RSSCP.
Thanks for your blessings, sir. Regards. Now I would like to call upon the President-elect, Sir Dr. Naveen Malhotra, sir, to say a few words. Naveen, sir, please.
Greetings to all on the 39th Foundation Day of Research Society of Anesthesiology Clinical Pharmacology. I pay my regards to Patron Dr. Tej Kaul, sir, President Dr. Indrani Hemant Kumar, all the members of the Governing Council, office bearers, past presidents, past organizing chairpersons, organizing secretaries, scientific committee chairpersons of RSSCP-Con in the last 1 decade or so. Today, it's a very proud moment for all of us when we are celebrating 39th Foundation Day of RSSCP. Research Society of Anesthesiology Clinical Pharmacology is dedicated to academics and research, and it is always committed to the clinical welfare of the patients. Let's keep on working together with full zeal and enthusiasm in the larger interest of the patients, our students, and future generations. We can take RSSCP to new heights under the able leadership of the current president and secretary, and also support of all the governing council members. Today's function was initially planned to be a physical one, but COVID has taught to be flexible and we are meeting online. And I'm happy to say that Dr. Vishal and Dr. Indrani invited the organizing chairpersons and secretaries, those who were available, those who have conducted RSSCP-Con conferences, CMEs, workshops in the last 1 decade or so. So I'm very happy that Dr. Paul from Dehradun, Scientific Committee Chairperson of RSSCP-Con 2014, Anil Verma, the Organizing Chairperson of RSSCP-Con 2017, Dr. Ashok Kumar, Organizing Chairperson of RSSCP-Con 2016. They have joined us today, and we have other dignitaries who will be sharing their experiences with us. Let's again resolve to take RSSCP to new heights. I extend once again congratulations to all of us. Thank you very much. Thank you, RSSCP.
Thank you very much, sir. Now, taking the program further, I would like to begin with the scientific session. And first topic is anesthesia in a child with chronic kidney disease. And I would like to call upon the chairpersons, Dr. Anju Garewal, madam, the vice president of the organization, Dr. Meena, madam, joint secretary of RSSCP, and Dr. Nishkars, GC member of the RSSCP. And the speaker is Dr. Ellen Dias from Mumbai. Dr. Anju Garewal.
Thank you so much, Dr. Vishal. A very happy Foundation Day to all of us, and I echo the sentiments of all my, seniors around here. So without much ado, I'd like to introduce our speaker. I'm really happy to introduce Dr. Ellen Dias. She is an assistant professor at the Department of Pediatric Anesthesia at the SAIT GSMC and KEM Hospital, Mumbai. She has the privilege of being a DM in pediatric and neonatal anesthesia, which is, I would believe, a rarity for us, but it's indeed very heartening. She also is a recipient of the KPR Young Anesthesiologist Awards. A very prestigious award, has been awarded the Special Achievement Awards at the ISACON Maharashtra, and of course has the ISA Best Original Article Award as well, with multiple PubMed indexed publications to her credit. So with a major area of interest being pediatric and neonatal anesthesia, I believe she's the right candidate to talk to us on anesthesia in a child with chronic kidney disease. Over to you, Dr. Raylene.
Thank you so much, madam. And thank you all the eminent seniors and Indrani, madam, Vishal, sir, for giving me this opportunity. And it indeed is a great honor to be given this opportunity to present today. So I'd like to move on to my topic. And I'm going to be speaking on a child with CKD. So we will see, I'll just touch upon the causes of CKD in kids because they are a little different from adults. We'll see staging and investigations, the systemic effects of CKD. I'll touch upon anemia, hypertension, and electrolyte imbalance in short. We'll see a little bit on anesthetic agents and monitoring. And if time permits, I would like to, just touch upon a few differences between in pediatric transplant. So the KDIGO, the Kidney Disease Improving Global Outcomes, has laid down a pediatric definition for CKD. So one or two of these criteria have to be fulfilled. The GFR is less than 90 for more than 3 months, or you may have an elevated GFR, but it has to be accompanied by structural renal damage, either in the form of an abnormality on renal ultrasound like cysts or dysplasia, and you can have hematuria, proteinuria. So if this is present for more than 3 months, then they also classify as CKD. So a lot of neonates may come under this definition. So we'll see the causes of CRF in children, which are different, like unlike in adults where you have renovascular disease or metabolic causes, which are, the commonest. In children, we have renal dysplasia or reflux nephropathy, which is the leading cause of CKD, followed by obstructive uropathy, and then come the glomerular diseases and the congenital nephrotics. So this reflux nephropathy or dysplasia, they are commonly graded as CA, KUT or KCUT, which is congenital anomaly of the kidney and the urinary tract. So how do we calculate the estimated GFR in a child? It varies with different age groups, but just to remember in short, we can use the traceable Schwartz equation, which is 0.41 into height in centimeters divided by the serum creatinine. Now, KDIGO recommends both creatinine and cystatin C clearance in children to estimate the GFR. But in our institute, we do not have cystatin C. It's pretty expensive. So we use only the creatinine clearance. However, cystatin C is a better method because, unlike creatinine, it does not get affected by muscle mass, by certain drugs. With puberty, it will not increase. But it is expensive and it takes around 3 days for the values to come. So if we see GFR by age, in preterms, it is less. And that is because nephrogenesis is not complete before 34 weeks. Also, the renal blood flow is relatively low. So at term, it slowly starts increasing. But between 2 to 8 weeks, you can see here there is a dramatic rise in the GFR. And this is called the honeymoon period, where if you are, noticing children in the NICU, you may suddenly see an increase in the GFR and the creatinine values suddenly going down, although they may have CKD. So then adult values are finally reached by, around 2 years. So the staging in children is the same like in adults, minor differences. So stage 1 is a mild disease where the GFR is elevated. But as I said, you may get abnormal urine analysis. Stage 2 again is a mild disease. Stage 3, you start getting, your chronic renal insufficiency. That is a moderate disease where anemia and fluid overload and hypertension begins to set in. From stage 4, this is a frank or full-blown failure. So this is a severe disease where your electrolyte and metabolic derangement start. Now, children are considered for transplant immediately. Once they come into stage 4 itself, they start, shortlisting them on transplant lists. So then we have stage 5, which is the stage where uremia finally sets in, and this is the end stage. And if they are on dialysis, it is stage 5D. So this definitely requires some form of renal replacement therapy. So let's see how the renal physiology in children is different from that in adults. So the GFR is 25% of the adult level, and it reaches adult level by 2 years, that I just said. So these neonatal kidneys, they actually have a limited concentrating ability, where, they can concentrate maximum up to 600 milliosmoles per liter. If you compare it to adults, where we can go up to 1800. However, the diluting ability is maintained. So water-loaded infants, they can get rid of excess water and they can excrete very dilute urine. Now, this is what I was talking about, the honeymoon phase here. And if you see the renal, the renal blood flow here, the percentage of GFR, and this is with age. So you see from birth to, it slightly increases, but then from 2 weeks to 8 weeks, there is a steep rise, and this is the honeymoon phase. And you will notice this in the NICU. But later on, again, it plateaus. So in children who are having cardiac disease, who are premature, or those who are in the ICU, you want to be careful to maintain the renal perfusion pressures, and you want to avoid hypotension for these reasons. A word on sodium homeostasis. So this is maintained till 90% of renal function is lost. So till very later on, it's actually maintained. And if you see, they have more of a tendency for sodium retention. So elimination is not possible. But in case of negative sodium balance, they can retain sodium. But however, in later stages, if the concentrating defect is very severe, they can have, they can have both of the things into play. Whereas potassium homeostasis, also it is maintained till the very later stages. 85% of potassium load is excreted by kidney and 15% through the colon. So children who are constipated, you have to be aware that there is another source of potassium here. Now, the ICF is the second depot of potassium, and this flux, this transcellular flux is impaired. And therefore, this lag is responsible for the dangerous hyperkalemia. And most of the mortality or morbidity in children with CKD is because of potassium and the cardiac arrhythmias that you get attributed to potassium. So I'll just talk about effects on multiple organ systems. The cardiovascular system, where you have renin production, which increases because of the diseased kidneys. And just three things we need to remember in children: they will have hypertension, LVH, and a diastolic dysfunction. Then we have the anemia of CKD due to erythropoietin reduction. There are multiple mechanisms of anemia. These children, they may be oliguric or they may be polyuric. So you will have, you can get both pictures. They will be overloaded and hypertensive, or they can be hypovolemic and hypotensive. Electrolyte fluxes, like I said, are very common, and these predispose them to the seizures or neurologic damage. So uremia is not excreted, and that causes the CNS depression, uremic cardiomyopathy, and this is what impairs platelet function. Pleural effusions, pulmonary edema are seen earlier on, but in later stages, because fibrosis actually sets in, so you can get a more of a restrictive pattern, or you will get a mixed pulmonary function test. Again, the dynamic disease of bones, where you can get fractures. This is because of phosphates are not excreted, so parathyroid hormone increases. Calcium is leached from bones. And they are in a state of chronic metabolic acidosis and it's an anion gap acidosis because of accumulation of phosphates and sulfates. So all these children, they are very prone not only for growth retardation, but they will also have some amount of developmental delay. And finally, they are, most of them, they may be 4 years, 5 years, but if you look at them, they will just look like a 1-year-old child, and very small, very frail, but they will be chronically hypertensive and acidotic. So in children, we also want to look at other comorbidities. So we talk of the Vactral group, where the C is the cardiac, then T is tracheoesophageal, and R, they have renal anomalies. They may have a single kidney or a horseshoe-shaped kidney or any such thing. Charge, again, the R is for renal. But I want to draw your attention to two syndromes, Prune belly and Potter's syndrome. So these Potter's syndrome children, their main problem is because of renal agenesis. So they have oligohydramnios, which causes, the entire other set of picture, the faces. And the most important thing here, these children, they usually come for posterior urethral valves and the fulguration. So you have to remember that they have pulmonary hypoplasia, and they may require some sort of ventilatory support post-operatively as well. Again, a word on nephrotic syndrome and glomerulonephritis. So children are usually transplanted earlier on. Like I said, the minute they come into, stage 3 to stage 4, they are put on transplant list. But in these two conditions, they are usually dialyzed before transplant, because it's very difficult to control their blood pressure in these conditions. Let's see the commonly performed surgical procedures. So children with CKD, they are prone to any other illnesses like other normal children, and they may come for any surgeries. But in specific, they may come for renal biopsies, sitting of the vascular lines for hemodialysis, sitting of peritoneal dialysis catheters, for radiological procedures in VIR like nephrostomy insertions. Commonly, the ones with the, with the reflux nephropathies, they come for bilateral ureteric reimplantations or unilateral reimplantations. Nephrectomies, again, are very common. And finally, they come for transplantation. So all of these procedures may be laparoscopic or robotic. And finally, after transplant also, they may come for procedures. And the commonest is a renal biopsy. So we ask for the routine investigations in these children, but in addition, they will have an ultrasound, and it's good to look at it. And if you can see here, these are polycystic kidneys. You can see the multiple cysts here, and I've put a picture here of a normal kidney. You can see they are hypoechoic, and the corticomedullary differentiation is maintained. So if you compare it to these kidneys, they are, CKD kidneys are usually hyperechoic, and the CM differentiation is lost. Then the micturating cystourethrogram, they may have that investigation with them. So you can see here the dilated posterior urethral valve, and here the grades of reflux. This is a grade 5 reflux. And finally, a lot of them will also have a technician scan. So you can look at the scan to see renal scarring. You can see differential function. You can see here cortical scarring. So what are the additional investigations that one might ask for? And, we need to know when these are mandatory. So there are KDIGO guidelines for these as well. So a coagulation profile is usually asked in stage 5 CKD onwards because of uremia. So the uremic toxins actually, they cause the platelet function to get affected. So here the best and the simplest test that you can do is a bleeding time, clotting time. It's a bedside test. ASA task force does not routinely recommend functional analysis. It's quite expensive. It's not readily available in all labs. But if you're doing a supramajor surgery, it will be good if you have TEG or ROTEM analysis. Again, you can intraoperatively transfuse them with estrogen, or you can give them desmopressin or cryoprecipitate to act on the bleeding because of the uremic toxins. Echocardiogram, again, if there is impaired LV function, children who are on antihypertensives, who are having proteinuria. So children who are in stage 3 to 5, you would want to ask for an echo in them. Also, if you're suspecting pericardial effusion, it's good to have an echo. Electrolytes are important in all children. And if they are on soda bicarb and chronic metabolic acidosis, you can ask for a VBG on the morning of surgery. So children who are on dialysis, usually dialysis is performed at least 24 hours before elective surgery. But in an emergency, you may need to go ahead. So there we at least wait for 4 to 6 hours to allow body fluids to re-equilibrate. But if you do not have that much of time, you can go in for a minimal or for a heparin-free hemodialysis. So always note down the dry weight of the child. That is the weight at which there won't be any signs of fluid overload. But below that weight, the child will have signs of hypotension. And again, serum electrolytes, hematocrit, renal function, and weight loss should be assessed immediately after dialysis. Now, children who are on dialysis, the dialysis. The AV fistula and all will usually they are on peritoneal dialysis, but the bigger children may have an AV fistula, so that is usually on the non-dominant hand. So all your other monitoring and your IV lines should be on the other hand, and you have to pad the fistula and take care of it. So we look at anemia in CKD children. Now, unlike in adults where the hemoglobin target is kept very low, children with CKD, their hemoglobin is kept a little on the higher side, 11 to 12. So this is always treated preoperatively, and oral iron is always started very earlier on, and it has to be supplemented with vitamin C, folic acid, and vitamin B12 because all these are deficient in CKD kids. So these are the iron preparations which are approved in children. Regarding erythropoietin, there is a risk of thrombosis in children, but it improves the quality of life, it improves the cardiac status, it improves their growth, cognitive function, and it avoids unnecessary transfusion. So it's good to start these children earlier on erythropoietin. Now let's see this child. She was a 5-year-old posted for a left nephrectomy. She had a grade 5 VUR, and she was on enalapril. So and on soda mint as well. So what are the guidelines now regarding ACE inhibitors? Now children are very commonly started on ACE inhibitors. Right now they are the number one drugs. A lot of old timers still prefer calcium channel blockers, but now the trend is moving towards ACE inhibitors. So a lot of them will be on these drugs. And our current guidelines say that ACE inhibitors should be stopped a day prior to surgery. However, these children, especially if they are supramajor surgeries, they are at a lot of risk of hypertension hypertension interop. So we, in our institute, we do not stop these drugs, especially if they are well controlled, but we titrate the dose so that it goes at least 12 hours prior to induction. Soda mint is indicated only if bicarb levels are less than 22, and you can give this on the morning of surgery with sips of water. You ensure that they are on all the supplements that need to be started. Pre-medication with antacids. Now, certain authors like Cote say that children are not at risk for decreased, gastric emptying times. But recent evidence has shown that even children are at risk. So antacid and pre-medication is recommended in these children. And remember, do not withhold sedative pre-medication, because these kids will come for multiple procedures and they are at very, multiple hospital visits. So they are going to have a lot of anxiety. We look at hypertension. So it is basically because of the activation of the renin-angiotensin system. Then uremia also increases the sympathetic tone, and all of this will increase your peripheral resistance. The fluid overload will increase your cardiac output. So let's see, in children, we need to look up the charts for the percentiles for, for age, sex, and height. And then less than the 90th percentile is normal. Between 90 to 95th percentile, they are classified as pre-hypertensive, and above the 95th percentile, they are stage 1 hypertension, and above the 99th percentile, they are stage 2 hypertension. So usually, we aim for to get it below this 95th percentile. But KDIGO 2021 came up with new guidelines, which now say that you need a very tight control of blood pressure in children. So they actually now target less than the 50th percentile. So this means that most of our children will be on very high doses of one drug, or they will be on multiple drugs. So ACE inhibitors or angiotensin receptor blockers are the first line therapy. They lower proteinuria, they are well tolerated, they slow the progression of renal failure. But like I said, since we are targeting 50th percentile, most children will need more than one drug. So then we move on to calcium channel blockers. They are well tolerated in kids, amlodipine, verapamil, nifedipine. They have pediatric labeling and no dose reduction is required. Beta blockers are used as second line therapy, so they require dose reduction as CKD progresses, and they are contraindicated in asthma. You have to be careful in children with heart failure, and they require dose reduction. So what about diuretics? Like, unlike adults where diuretics are started very earlier on, children won't normally be on diuretics. So, but if there is hypervolemia, thiazides and loop diuretics can both be started. They have good side effect profiles. But once the GFR falls less than 30, thiazides become ineffective. And in CKD stage 4 and 5, even your LASIK dose has to be reduced. So you monitor for volume depletion and electrolyte disturbances in all children who are on diuretics. So this is how we treat them. We start with one drug. Usually it's an ACE inhibitor. We increase it up to maximum dose. Then we move on to a second line drug. It's usually a calcium channel blocker. And you can move on to a third drug. If you're needing more than 2 drugs, then it's better to consult an expert physician. So intraoperatively, we usually manage hypertensive crisis by increasing the depth of anesthesia. Dexmedetomidine is a wonderful drug. Enalaprilat, esmolol, labetalol, all these are available in IV formulations. Nifedipine is very commonly given in children. It has to, we give it sublingually, and you can repeat the dose every 4 to 6 hours. SNP, NTG, again, they can cause reflex tachycardia, so we avoid these drugs. Now, what are the strategies for renal protection? So this is the same like in adults. We've always been taught to maintain optimum hemodynamics, intravascular volume, avoid, hypertensive surges, avoid hypotension, ensure that the kidneys are well perfused and the child is well preloaded. But in children, you have a very small margin because they immediately go into fluid overload. So also remember, most of these kids, they will have a list with them of nephrotoxic drugs. So if you can have that list present with you. So there are certain antibiotics which require dose adjustments like meropenem, etc. Contrast agents again and NSAIDs are nephrotoxic. Also, some of the immunosuppressants are nephrotoxic. So we'll just a word on anesthetics affected by renal failure. So most of these are same as in adults. The medications with increased volume of distribution like propofol, rocuronium, and thiopentone, your induction, they have a slower onset of action. So you increase your induction dose, but the duration of action is unchanged. So subsequent doses will be unchanged. Whereas medications with decreased clearance, which are, mostly cleared by renal mechanisms. So these are your anticholinergics, neostigmine, and your steroidal muscle relaxants. So here you have to increase the interval between serial doses, and opioids, most of them which have active metabolites, you have to reduce the dose by 30 to 50%. So always prefer hepatic medically cleared drugs and drugs which do not have active metabolites if you are suspecting delayed graft function. So I'll talk about delayed graft function a little later. Inhalationals and relaxants, all three can be used. Sevoflurane, actually, there really is no more controversy. In our institute, we go below flows of 1 liter per minute. See, the fluoride ions or the compound, it does not have any effect on the native kidney, but on the renal allograft, really there is no much evidence. So we do not know that that effect. So most authors do recommend not to go below flows of 1 liter per minute in children with CKD. Muscle relaxants, you can use succinylcholine if potassium levels are normal. However, the best relaxants are atracurim or cisatracurim. Vecuronium, the duration of action is increased also. Around 40% of it is eliminated by the kidneys, and there are active metabolites. Gamma Dex not available currently in India, but it will come soon. So the complex is eliminated exclusively by kidneys. Actually, theoretically, there would be a risk in children, but most case reports in children with CRF have shown no side effects. And if the transplantation is successful, the GFR infiltration is quickly restored and the complex gets eliminated. So always use a nerve stimulator to monitor neuromuscular block. Anesthesia for minor procedures like a renal biopsy, you can do it with inhalational agents. You can use a face mask or an LMA. For major procedures, a modified RSI should be done. And always remember, if there is fluid overload, you should use a smaller than predicted tracheal tube. Now, intraoperative fluid management, the major concerns are in your major surgery, hemorrhage, the renal clamping, you have to preserve renal function. You have to, optimize and monitor intravascular volume. So which fluid to choose? Now, again, most nephrologists still prefer normal saline, and even when they perfuse the allograft, they perfuse it with normal saline. So in our institute, the nephrologist actually, she likes to give normal saline and alternate it with Ringer's lactate, and she even makes us do that. But however, there are risks with normal saline. Too much of normal saline, it can suppress the renal blood flow because of the high chloride content. So RL is slightly hypotonic. The lactic acidosis may interfere with your estimation of, if there is hypotension or if there is lactic acidosis, you won't know what to attribute it to. So the best are the acetate containing balanced electrolyte solutions like Plasmalite. Oliguric children, the boluses, we do not give them 20 ml per kg. Everything is reduced to half. So each bolus will be around 5 to 10 ml per kg. And even your 4-to-1 rule in the anuric or oliguric patient has to be reduced by 50%. Tight glucose control is recommended. So routine monitoring for all procedures in the supra major procedures, cardiac output monitoring, you can assess fluid responsiveness. Now, central venous access, this Hickman catheter, if they come with this is never to be used. Only in an emergency, if you really need it, if you do not have any other access, with full aseptic precaution, and lock the line after use with heparin. So arterial lines, unlike in adults where the threshold is very high, in children, we do need to put in invasive arterial lines for supramajor procedures. So again, here, the femoral artery is avoided in case of transplants because of the risk of thrombosis in the transplanted kidney. And you have to be, avoid risking of a future AV shunt if it may come. So the same child who was on enalapril, intraoperatively, there were these tall T waves on ECG. So like I said previously, children are at high risk for sudden cardiac death because of dangerous arrhythmias due to hyperkalemia. So we have an ABG machine with us in our OT. So we immediately got the the VBG, which gave us serum potassium of 7. Now, children usually in neonates, potassium levels up to 6.5 is normal. And if it goes above 7, we start worrying and we start treating. And in other children, we accept up to 5.5. If it goes up above 5.5 to 6, we start treating. So in children, remember, you can get any of these ECG changes at any levels of potassium. It's not necessary that it will follow this trend only. Again, how do we treat it? So you have to reverse membrane effects. For that, we give calcium gluconate. And to transfer potassium for the transcellular flux, we give salbutamol. Now, salbutamol nebulization here in these children, you require very high doses. So 8 times the asthma dose. And this is, 2.5 milligrams. This is an entire respule that you would need to give a child who is less than 25 kg. So it's a very high dose. This was a 1-year-old child. I've chosen this case because it was a bilateral ureteric reimplantation. So how do you actually assess blood loss in these children? It's very difficult because most of the blood is diluted with urine. So the best method is, if you have a VBG, you can, it can help you to guide therapy. If you have Massimo route, you can again see trends. But remember, in children, transfusion is never based on a hemoglobin number. You have to look at trends, and you have to see if there is impaired oxygen delivery. So we use indices like urine output, lactates, bradycardia, or hypotension, and the rate of blood transfusion is also based on these indices. So this child was given 10 ml per kg of packed red blood cells. Now, should calcium be given prophylactically to this child after a blood transfusion? So the current guidelines say that calcium should be given only if you are prophylactically, only if you are transfusing citrated products like FFP or whole blood, and if the infusion rate is very high. So otherwise, for all other children, you have to measure, and only if there is documented hypocalcemia, then you can transfuse. What about soda bicarb? So in children, again, empirically, we never give soda bicarb empirically, because even alkalosis is a possibility with blood transfusion. So it is currently recommended only if there is severe metabolic acidosis, or if your pH is less than 7.25, or if there is documented hyperkalemia, only then you treat. The options for analgesia are varied. You can use your caudal epidurals. Again, be careful if you're of using morphine. We usually use clonidine. You can use your lumbar epidural catheters, tap blocks with catheters. IV paracetamol can be given. Dexmedetomidine, we usually give them at emergence. And for the surgeries which have these bladder spasms, like even in VUR and all, so ketorolac works very well for these kids. And, we give it round the clock 6 hourly, 0.5 mg per kg dose. So I'll just talk about renal replacement therapies in short in kids. So the number one thing is transplant. We always want to go ahead with a transplant before starting anything else, except in those 2 conditions which I said, in nephrotics and in FSGS. So they are usually started on either peritoneal dialysis or hemodialysis. So peritoneal dialysis is very easy. It's commonly performed in the IPCUs. You do not need very sophisticated equipment, but it is quite tedious, and you require a lot of manpower for that. So indications to start children on dialysis: the first indication is cessation of growth and development due to lack of energy. And then if there is excessive uremia, untreatable hyperkalemia, fluid overload, then they are started on dialysis. So transplantation in children is a little different than in adults. So living donor transplants are kept for children. Extended criteria donors are usually not given to children. So best outcomes are achieved if they are transplanted preemptively before dialysis. In living donors, in children, if they are less than 5 years, they have very good prognosis, but the weight should be at least 10 kgs at the time of transplantation. So adult, there is a difference in the donors. So the very small kids, they are actually given big kidneys. So this is because if they are given the small kidneys, from donors less than 20 kgs, there is a high chance of vascular thrombosis. So this discrepancy in the size is going to cause a lot of cardiac output changes, because now the cardiac output has to cope with the demands of this large transplanted kidney. So on the other hand, the small pediatric donors, that less than 20 kgs, those small kidneys are kept for older children or for adult recipients. Immunosuppression, we need to know. So different institutes have different protocols, and anesthetists are expected to start the induction immunosuppression. So this is what we do in our institute. A lot of institutes also use basiliximab. So we give this anti-thymocyte globulin, and it is usually derived from an equine or a rabbit source. So, it's given at the time of induction itself. 1.5 mg per kg, we dilute it in 100 ml normal saline and give it slowly over 6 hours. Now, because of the source, there is a high chance of cytokine storm, bronchospasm and all. So we always give it only after giving methylprednisolone. And then maintenance immunosuppression is usually done with corticosteroids or antimetabolites. Now, vascular clamping, if you can see here in adults, usually it is between, between the iliac vessels, whereas in children, because of the discrepancy in the size and because we want to avoid the vascular thrombosis, the anastomosis is usually done directly to the aorta and the IVC. Also, another difference in pediatric transplants, the kidney is not placed retroperitoneally, it is placed intra-abdominally. So heparin low dose, again, unlike in adults where we give around 100 units per kg, in children we give only 35 to 50 units per kg before cross clamping. And prior to reperfusion, the CVPs are maintained high. Now, a lot of institutes give soda bicarb or mannitol, but it depends. Generally, for a living donor, you need not give mannitol. So synthetic colloids are not recommended at all. We use albumin. You can give 25% albumin, 1 to 2 ml per kg. RBCs are transfused only if HB is less than 8. So this was an algorithm which was published recently in Pediatric Anesthesia Journal, for hemodynamic therapy guided by blood pressure and cardiac output measurements. So you look at your mean arterial pressure and you always want to maintain it at 70 in kids. Now, if your MAP is low, you give a fluid and your cardiac output is normal, you give a fluid bolus and you see if it improves, well and good. If no, you start norepinephrine. However, if your cardiac output is also low, you give a fluid bolus, but if it doesn't improve, you directly start them on Dobute. So the problems in pediatric transplantation, they are at greater risk of intraoperative hypothermia. Wound closure is difficult because of the large size adult kidney. So you can have abdominal compartment syndrome, difficulties with ventilation, hemodynamic complications. Like I said, you aim at a MAP above 70, or you look at that, when you after release of the vascular clamps, you see at which MAP there is adequate perfusion, and you can stick to that MAP and maintain that. So post-transplantation, children are immunologically naive. So acute rejection is not very common, but the most common complication is renal vein or artery thrombosis. Delayed graft function, again, dialysis needs to be continued here immediately from the 3rd or 4th day onwards within the first week itself. So this is usually if the cold ischemia times are more than 660 minutes now. So all that can, or if you have not maintained your pressures intraoperatively, because the graft, the allograft does not have innervation. So this can be reduced simply by living donors, and that is what we do. Whether this ischemia time can be reduced to less than an hour. Sepsis, hemorrhage, hypertension are other complications. And in post-transplanted recipients, remember that although they are transplanted, the hypertension, diastolic dysfunction, LVH persists, the pulmonary edema resolves, but restrictive lung function will persist. So even you have to be careful of hypoperfusion because of the allograft. It's not innervated. Avoid nephrotoxic drugs. The immunosuppressants have to be continued, and they are always going to be at very high, psychological stress or anxiety. So renal dysplasia or reflux is the commonest cause of CKD in kids. GFR is low at birth, and these kidneys have limited concentrating ability. CKD affects multiple organ systems. Children are transplanted preemptively, and they have superior outcomes with those who are dialysis dependent. Preoperatively, we optimize them, with tight BP control and get the hemoglobin to normal. We avoid unnecessary blood transfusions, and appropriate intraoperative care is important. Thank you very much.
Thank you so much, Dr. Reddy. It was indeed a pleasure and a treat to listen to you.
Thank you so much, madam.
A privilege to listen to you previously as well, and you're so very well done the whole talk. I wish we had more postgraduates here to listen to you. It's so comprehensively covered.
Thank you so much, madam.
Invite questions if they are, and also invite my co-chairpersons. So I believe the questions would be posted in due time,
Okay.
But then I had a kind of a random query.
Yes,
since these children, they might have like underlying cardiac left ventricular hypertrophies and all those involvement, and if they are scheduled for an extra major procedure, or say they are being recipients, is there any role for doing a more invasive testing for cardiac testing?
Like, madam?
Like say stress, W2 means stress echo.
Madam, we routinely don't do it, but they would require a good, cardiac, they would require a pediatric cardiologist to look at the diastolic dysfunction and see how severe that is. And maybe, yeah, if there is severe diastolic dysfunction, then yeah, maybe they would require further testing. But in our institute, we don't routinely do it.
Thank you so much.
Thank you, madam.
Do we have further questions? Anybody?
Ma'am, I want to ask one question to madam.
Yeah.
What is the optimal time for the dialysis beforehand, ma'am, for any other surgery of a CKD patient?
Usually 12 to 24 hours. That is optimal because they require at least 12 hours for the body fluids to re-equilibrate. But if, like I said, if in an emergency it cannot be avoided, then we give them a heparin-free dialysis. And then, within 2 hours also you can take up if it's a heparin-free. But
Right.
but we require the electrolyte levels then, because there is again a possibility of disequilibrium.
Right. Thank you very much.
Thank you, sir.
Dr. Helen, what
Yes.
is the minimum weight or the age at which renal transplant can be?
Madam, at least 10 kgs. So age, there is actually no cutoff, but they usually they have to cross the infancy stage. But 10 kgs is the minimum weight. Below 10 kgs, we don't take them up. They have to be at least 10 and above. And that is a universally accepted.
And the safest analgesic agent that should be used for pain in these patients?
Madam, paracetamol, and we use
What about buprenorphine?
ketorolac.
Acha, and
Yeah. You can use buprenorphine. You
patch
can
can
use.
be
Yeah.
used.
Yes.
You said that ketorolac is also another safe
Yes.
option.
Yes. No. We give them ketorolac. It's safe. 0.5 mg per kg.
Ketorolac doesn't affect the kidney functions?
We have not seen any effects with that, and our nephrologist also doesn't believe that it affects, because we ask them routinely, since it also comes in that class. But we give it routinely.
So any role for any, I know of course they'll have lead older children for any regional anesthesia techniques up there for them. Of course, we're not looking at infants, but perhaps
Right.
older children.
Yeah, madam. Any of this thing techniques,
also.
you can use an epidural or a tap block. Catheters also, we use tap catheters as well. QL also.
Okay.
So if we implant a kidney from an adult donor to a small child, so doesn't wound closure, the abdominal closure might also be a
Right.
problem sometimes?
So yeah, so they may not do a primary closure initially. They may take up at a later stage. So they give some time for, especially if the intra-abdominal pressures are high, if you're needing very high peak airway pressures. So then they hold on and they take up at a later stage for complete closure. It's a common problem.
Yeah.
So we can wind up, Anju madam?
Yeah, I think we have just one question coming up, role of anesthesia, as we discussed just now. Yeah. They want to know is the role of erector spinae block. I believe you can kind of take it up and.
Yeah. It can be used.
Yeah.
So what matters is what you're giving in the block. So
Yes.
you have to avoid drugs which are which have active metabolites, or like morphine. Those kind of
For purpose of sedation and analgesia in the ventilated patients, what do you prefer to use?
So we give them midazolam fentanyl infusion.
You have also mentioned dexmedetomidine.
Yeah.
What is your experience in using, especially in infants,
Yeah. So especially for dexmedetomidine, we give at the time of induction. We give it just prior to extubation for the emergence. Intra-op also we give bolus doses if needed. But for post-operative, I've noticed that, if we start dexmedetomidine infusion after 24 to 48 hours, they start going into that bradycardia. So then we need to stop it. And then we need to start something else. But it works very well for those first 24 to 48 hours. So then we give a break and, we cover up with midazolam or fentanyl. And then if they are needing further ventilation, then again we restart dexmedetomidine after a while, just because of that bradycardia.
Thank you so much, Dr. Raylene. It was
Thank
indeed
you,
a pleasure
madam.
listening to you, and a topic that perhaps all of us needed an update. Thank you. And I hand over the mic to Dr. Vishal. And I also thank the entire organizing team on behalf of my co-chairpersons. Long live RSSCP and a very happy Foundation Day to all of us. Let us carry forth the torch that has been given to us by our predecessors and our mentors. Thank you. Over to you, Dr. Vishal.
Thank you very much, ma'am. Thank you very much, Dr. Raylene. Moving on further, we have next topic is fasting guidelines and fluid management in pediatric patients by Dr. Shubdeep, and the chairpersons would be Dr. S.P. Sharma, sir, and Dr. Pradeep Bhatia, sir, Dr. Rakhi Goel, ma'am. Dr. S.P. Sharma, sir.
Yeah.
Dr. S.P. Sharma, sir, is the ex-president of the society. Dr. Pradeep Bhatia, sir, is chief editor of JOCP, and Dr. Rakhi Goel, ma'am, is the GC member. I would like to call upon Dr. S.P. Sharma, sir, to welcome and introduce Dr. Shubdeep, sir.
Yeah. Good evening and happy Foundation Day of RSCP to all. And this is so nice to see all you on this celebrity day, and I congratulate the whole team for organizing this webinar on this esteemed day. Now, in the continuation, now next lecture is will be given by the Dr. Shubdeep. She is Associate Professor in the Sri Guru Ram Das Institute of Medical Science and Research Center in Amritsar. Areas of interest are pediatric anesthesia, airway management, cardiopulmonary resuscitation, and simulation-based teaching, AHA, ACLS, and ASPA TPS instructor. And I invite her. It's a very important topic. And management, fluid management in the pediatric anesthesia. Dr. Shubdeep, please.
Dr. Shubdeep, can you hear me, Dr. Shubdeep?
Yes, am I audible?
Yeah, please.
Yeah, I hope you can see me. Just a moment for me to. Can you see my screen now?
Yes, ma'am, it's visible.
Yes.
Please put it on the slideshow mode, ma'am.
Yeah. Okay. Are we good? Can we see this?
Yes,
Yeah.
yes, please go ahead, ma'am.
Yeah, please. Thank you so much. A very good evening, everybody, and congratulations on the RSSCP Foundation Day. And thank you very much for giving me this opportunity to present at this August forum. So I'll be talking on perioperative fasting guidelines and fluid management in the pediatric patient. So preoperative fasting, it is the prescribed time prior to any procedure which is done under general or regional anesthesia or under procedural sedation, when oral intake of liquids or solids is not allowed. What is the need for this? It is to reduce the gastric volume and the acidity in order to prevent pulmonary aspiration of gastric content and aspiration pneumonitis. So this was highlighted after the publication of 1946 by Mendelssohn, who highlighted aspiration pneumonitis and the pulmonary complications. And since then, the NDM after midnight has been a rule. But the trends, they changed after in the late 1990s, and the guidelines now, they have been more of like 642. We are following the 642 rule, where it is 6 hours fasting for a light meal and 4 hours for breast milk, and clear liquids, they are allowed up to 2 hours, and 2 hours NPO is recommended. But it has been seen with the current guidelines that in children, the fasting times, they far exceed the recommended timing. And it has been observed in a study that the fasting time for solids, the mean was about 12 hours, and for liquids, it was 8 hours. And 56% of children in this study, they reported being very hungry or starving, while 26% reported being very thirsty. So it was recommended that we need strategies to decrease the fasting period in order to decrease the discomfort of the children. So in another study on the fasting guidelines, so when it was observed while applying the 642 regimen, again, the fasting times, the median fasting times, they far exceeded what was recommended. Now, in this observational study from our very own PGI Chandigarh, it was observed that the compliance to instructions, it was very poor. The fasting instructions when given, the compliance was only 8.5%. And 88.4% of the patients, they fasted longer than advised. Again, alarming timing. 10 hours for solids and 9 hours for liquids. But it was observed that separate written fasting instructions given for liquids and solids, when given according to the order in the operating list, that improved the compliance. And majority of the parents, they held fluids from the children with the view that it will increase the post-operative nausea and vomiting. So why are we concerned with these prolonged fasting times? First of all, it increases the patient dissatisfaction, adds to the discomfort and irritability. Patients have those feelings of thirst, hunger, anxiety, and malaise. It can actually increase the incidence of nausea and vomiting. But it also mounts a stress response, which can cause hyperglycemia. It can lead to insulin resistance and lipolysis. And all this is not good for the post-op recovery of the child. Children, as we know, they have limited glycogen stores, so they can also land up in hypoglycemia and ketogenesis. Dehydration can also be a factor in small children, which can lead to hypoglycemia and instability. So going by this, an ultrasound assessment of gastric volume in children was done, and it showed that 10 to 15 ml per kg drink, when given 2 hours before surgery, it actually decreased the gastric volume. So here, the USG was done after an 8-hour fast, and then the children were given 10 to 15 ml per kg to drink 2 hours, and an ultrasound was done before the anesthesia induction. So when the fasting, when the gastric volumes, they were compared after 1 hour and 2 hours of fast. In 131 children, it was found that 1 hour fast didn't have any additional advantage of hunger, thirst, or parental satisfaction, but it produced similar gastric pH and residual volumes as the 2 hours fluid fast. This landmark figure, the apricot study, which was published in 2017, here we can see that amongst about 31,000 participants, the incidence of bronchial aspiration, it was only 29. So you can 10 per 10,000 anesthetic. And off-peak, the was very less. It was uneventful in 18, and none of the patients there, they were admitted to an intensive care unit. So this added with the factor that decreased fasting times, they do not actually increase the gastric the gastric volume or decrease the pH. It led us to think, is 2 hours too long? Because the 2-hour rule actually translates to longer fasting times, as has been observed by many authors. This prolonged fasting, it is unnecessary, causes discomfort and harm. Drinking water paradoxically reduces the gastric volume and increases the pH. And pulmonary aspiration, it is rare in children. And even if that clear fluid aspiration it occurs, it does not increase the morbidity. So this all led to the recommendations changing, and the APA consensus statement, it was issued in 2018, where they said that it is safe and recommended for all children able to take clear fluids to be allowed and encouraged to have them up to 1 hour before elective general anesthesia, if there are no contraindications. That is, if there is no chances of any delayed gastric emptying in the children. And this recommendation, this statement was also endorsed by multiple societies across Europe and Australia and New Zealand. The Canadian Pediatric Anesthesia Society, it also endorsed the guidelines where they said that the patients, they should be encouraged and allowed to ingest clear fluids up to 1 hour. Now, the recent guidelines, this is the European guidelines, the European Society of Anesthesiology. They have further decreased. The guideline was published in 2022, this year itself. And here they have made another change. They recommend reducing the clear fluid fasting to 1 hour and reducing the breast milk fasting to 3 hours. But all this change in the guidelines from that comfort zone of 642 to the 1 hour, it has led to certain questions. Is 1 hour the answer? The question or the debate has been because of a limited flexibility of the OR schedule. What if the child is not fasting and the OR is free? And the authors also cited that the current evidence is premature. This paper, it also questioned that is 1 hour actually an answer to the decreasing the discomfort and improving the satisfaction of children or parents? Will it actually translate to improved parent satisfaction? And is it actually possible to chase the perfect fasting time? With the 642, we were not able to achieve the ideal 2 hours. So is it possible with the 1 hour guideline? So certain recommendations to that sort, there have been some practices which are likely to improve this. This paper was published in 2018, and they compared a 642 fasting regimen versus a 640 fasting regimen. And this, in the 640, the children, they were encouraged or they were allowed to drink clear fluids till they were called to surgery. And this was typically half an hour before the procedure. So they were allowed to drink, and this actually decreased the median duration of fasting for clear fluids to 1 hour, while the duration of fasting in the 642 regimen was 4 hours. And the incidence of fasting more than 6 hours, it was reduced from 33.3% to 6.3%. So this actually appears something which can be achieved with improving the practice. And they notably, they also did not observe any untoward complications or aspirations or any respiratory complications in this study. But they also observed that it reduced anxiety, irritability, hunger, and thirst, and will contribute to the comfort and well-being of the children. Another similar campaign has been the Think Drink campaign, which was an innovative project established in 2015 at the Nottingham University Hospital. Here, during the OT briefing, there is a time called as the Think Drink movement, the Think Drink moment, where an identified team member clarifies with the anesthetist and the surgeon which patients can drink and until when, based on the expected cases. And this was an individualized and patient-based approach, which actually decreased the fasting times and improved the patient.
रिबन्स आहेत का आपल्याकडे कलर्ड रिबन्स आहे
The question is, why are we not following the preoperative fasting guidelines?
खायला बांधायचे दुसरे स्टार्स वगैरे आहेत का ते घेतात ते बांधायचे बघू तिकडे आहेत का बघ
Which children we want to see in our OR. So to allow them or to leave them thirsty. Now coming to the second part of my presentation, which is about the perioperative fluid management. The perioperative fluids, they are given with an objective to maintain homeostasis or re-establish the normal physiology and to also counteract the effects of anesthetic agents. The fluid requirements, normally we can divide them into maintenance requirements and replacement fluids. The maintenance is to replace the ongoing, the GI, renal or cutaneous losses, and the replacement is for the preoperative deficits, which may include fasting and ongoing losses, that is hemorrhage and third space losses. But we have to remember while treating our children that they are not small adults. They have some physiological differences. That is total body water in children, it is high. They have a high ECF to ICF ratio along with a low GFR. And extensive fluid losses leads to higher fluid requirement, which is because of an inherent higher metabolic rate and larger surface area to weight ratio and their faster breathing time. And we also have to recognize that nowadays, with the relaxed guidelines that are recommended, the preoperative fluid deficit, it can range from no deficit to severe deficit. So we have to individualize our approach. So our fluid therapy has been historically guided by this landmark paper published in 1970, I believe, by Holliday and Segar, where it was established that the maintenance of water, it parallels the energy expenditure of the body, that is 1 ml per kilocalorie. And according to these observations, the 4-2-1 rule, it was devised, and they also recommended that maintenance electrolytes, they should be replaced at 3 millikelins per 100 kilocalories per day for sodium, 2 for potassium, and 2 for chloride. These recommendations for the electrolytes, they were based on the composition of breast milk and cow's milk. So this has guided our perioperative fluid therapy, and we have been giving hypertonic fluids to our children, which include 5% dextrose with N/4 or N/2 normal saline or half normal saline or ringer lactate. Now, all of these, we know they are hypertonic solutions and they will lead to hyponatremia, and high percentage of dextrose will cause hyperglycemia, which are both deleterious. So in the late 90s, it was questioned, the traditional therapy was questioned with reports of hyponatremic encephalopathy and permanent neurological damage and death due to hyponatremic solution. And it was also recognized that stress-induced secretion of ADH in the perioperative period, it also has a part to play in this dangerous hyponatremia. This review, it also examined that the current practice is traditional and not evidence-based, And hypotonic fluids, they exacerbate the risk of hyponatremia. The odds ratio is 17. And isotonic fluids, contrastingly, they may be protective. While looking for a solution to the fluid management, it was observed that iatrogenic hyponatremia, it can be as high as 11 to 31%, that is the range. And the stress response leading to the secretion of ADH, it peaks at 6 to 12 hours after surgery, and it can be there up to 5 days. It normalizes after 5 days of surgery. And there could be any triggers: pain, stress, fever, vomiting, positive pressure ventilation, drugs including opioids, nitrous oxide, barbiturates, halothane, NSAIDs. Any of these, they can exacerbate the ADH response. This, along with the reduced ability of the kidneys to excrete free water, it affects our maintenance IV fluid volume. And so to decrease the incidence of hyponatremia, it was studied whether the type of fluid has to be changed or the volume is more important. And in this study, the authors, they examined normal saline versus half normal saline, which was given at 100% maintenance rate versus 50% maintenance rate. They examined the plasma electrolytes and ADH at induction 8 hours after surgery and 24 hours after surgery. And it was observed that the incidence of hyponatremia at 8 hours with half normal saline was 30%, while it was just 10% with normal saline. And they also observed a 2 to 4-fold increase in the plasma ADH. So it was concluded that isotonic saline solution decreases the risk of hyponatremia, while fluid restriction is not useful, and it may also lead to dehydration, which was observed in 23% of the patients. So hypotonic versus isotonic maintenance fluids. Another paper, it examined 258 post-operative patients with ages 6 months to 16 years. Hyponatremia was observed in 40.8% who received hypotonic fluids versus 22.7% children who received isotonic fluids. So the relative risk of hyponatremia was 44% less with the isotonic solution. And the isotonic solutions, they did not carry an extra risk of hypernatremia. So it was concluded that they are safer than the hypotonic parenteral solution. Now, another concern here is the hyperglycemia, because hyperglycemia, similar to hyponatremia, it can lead to detriment, it can be detrimental for the nervous system. And in addition, it also causes osmotic diuresis, which can cause dehydration and electrolyte abnormality. Hypoglycemia can also occur. The incidence of preoperative hypoglycemia is 0 to 2.5%, and this is with durations of 8 to 19 hours. The stress response, it alters, hypoglycemia alters the stress response to surgery, it alters the cerebral blood flow and metabolism, and it can also lead to permanent neurodevelopmental impairment, which is observed with severe hypoglycemia, blood glucose levels less than 45, or mild hypoglycemia with hypoxia or ischemia. So what fluid to give? 5% dextrose causes hyponatremia and hyperglycemia, while normal saline, it can cause, it will maintain the normonatremia, but it can lead to hypoglycemia, especially in the neonates who have a higher metabolic rate and higher risk of hypoglycemia and lipolysis. On the other hand, decreased oxygen consumption and decreased metabolic rate during anesthesia can cause decreased glucose requirement. So an isotonic balanced electrolyte solution with 1% glucose was tested in 66 neonates who belong to ASA 1 to ASA 4 classes. And they found that the intraoperative use at 10 ml per kg per hour, which was the mean rate that was delivered, it did not cause any hyponatremia or hypoglycemia or hyperglycemia, ketoacidosis, and the acid-base balance was also maintained. Another initiative, this all led to the Safe Thoughts initiative, where it was identified that moderate perioperative hyponatremia, it can cause subclinical neuronal damage, though it may not cause severe encephalopathy leading on to death immediately, but it can cause subclinical neuronal damage, which will be detectable only years after surgery, and that too with special neurocognitive testing. So we cannot establish a causality here, but we have to be careful. And therefore, we have to follow the checklist and maintain normonatremia and normoglycemia. With these arguments, they led to the development of guidelines for the intraoperative fluid therapy in children. These ones were published in 2011 by a German scientific working group for pediatric anesthesia. And they recommended that the IV fluids to be given intraoperatively, they should have an osmolarity and sodium content, which is close to the physiological range, and with an added 1 to 2.5% glucose, which will prevent hypoglycemia as well as hyperglycemia. And metabolic anions, they should be added to avoid acid-base imbalance. So acetate or lactate or malate, they should be added to a solution. The recent guidelines in 2017, they also acknowledge that the perioperative fasting times nowadays, they are as short as possible. Okay? It is recommended to be as short as possible. So a background infusions, the rates, they have to be seen, and the children, they do not have considerable deficits. So a balanced isotonic electrolyte solution with 1 to 2.5% glucose will provide an ideal background infusion. In patients with circulatory instability, however, an additional balanced salt solution, which is given without glucose, it should be administered until the desired effect is achieved. And colloids can be used to recover normovolemia and to avoid fluid overload. So to summarize, Sampleman et al. In 2019, they said that physiologically composed balanced isotonic electrolyte solutions, they are the answer. They will maintain homeostasis, optimize the pre-existing imbalances, and they carry a wide margin of safety in cases of accidental hyperperfusion. So how much do we give? Does one size fit all? Holiday and Cigar, which has been guiding our transfusions till now, they had relied on the assumption of adequate urinary output and the standard energy expenditure. But they did not account for non-osmotic stimuli for ADS secretion, low insensible fluid losses, which are often seen with the newer surgical techniques, and the vulnerability to hypervolemia in an acutely ill child. So in 1975, Furman et al., they had advised how to replace the preoperative deficit, and the rule of 4-2-1 based on the Holiday Cigar assumptions, it was devised. This was modified by Bailey et al. In 1986, who advised a bolus of basic salt solution over the first hour of surgery, ranging for 15 to 25 ml per kg for children different ages. But both these regimens, they are again not relevant because of the current fasting guidelines, because they assumed a fasting period of at least 6 to 8 hours. So how do we replace the preoperative fluids, is it required? If the child is fasting more than 6 hours, that is the only situation where we should give a fluid, and this should be based on the degree of dehydration. 1% dehydration amounts to 10 ml per kg fluid loss. And it should be replaced with a glucose-free crystalloid containing sodium in the range of 131 to 154 millimoles per liter. Can be delivered as a bolus of 20 ml per kg over 10 minutes, or in children, or 10 ml per kg over 10 minutes in neonates for a maximum of 40 to 60 ml per kg. We can use transthoracic echo for the assessment. This is a very readily available chart for assessing the dehydration on the bedside, and we can grade dehydration depending on this. Now, after the preoperative deficits, which are very negligible nowadays, the maintenance fluid therapy, how to give the maintenance fluids. The APA and the NICE guidelines, they follow the Holiday and Segar and recommend isotonic fluids. But they also, the NICE guidelines, recommend to restrict fluids by 50 to 80%, accounting for the non-osmotic ADH secretion, which can cause the risk of water retention. And the recommended fluids there, balanced electrolytes with 1 to 2.5% dextrose at the rate of 10 ml per kg per hour, which can be started as an initial infusion. And the rate is to be adjusted based on the requirement. To replace the ongoing losses during the intraoperative period, we have to consider what type of fluid deficit is there. Is it fluid or plasma or blood? And we can give isotonic solutions or colloids or blood based on the child's hematocrit. This is the APA guideline. The third space losses, this is a very controversial thing, and there is very limited evidence nowadays available, and they are very difficult to quantify, but still we have the estimation that is ranging from 2 ml per kg per hour for superficial surgery to 10 ml per kg per hour for abdominal surgery. So what do the guidelines say? The volume to be replaced, the NICE guidelines say replace the ongoing losses with isotonic saline. And they also recommend to give repeated doses of 10 to 20 ml per kg in cases of cardiovascular stability till a desired effect is achieved. Excess of crystalloids, they carry the risk of interstitial fluid overload leading to hemodilution and decreased oxygen supply. So we have to, the current recommendation is to follow an individualized goal-directed therapy, which can be guided by the pulse pressure and the stroke volume. Colloids, they are recommended only after 30 to 50 ml per kg of crystalloids to maintain intravascular osmotic pressure in specific cases. Routine transfusion is not advised. All of the crystalloids, they are comparable: albumin, gelatin, hydroxyethyl starch. They are all similar in their usage. And repeat dose infusions, ranging from 10 to 20 ml per kg, they can be given until the desired effect is achieved. They carry a risk, though, to leak into the interstitial space and worsen the edema and increase intravascular permeability, especially in critically ill children with sepsis, trauma, and burns. Now, coming to an important part, that is the replacement of blood. This is routinely in the surgery, in the surgical patient. So the intraoperative goal in a bleeding child is to maintain normovolemia and to avoid hypervolemia, to minimize swelling and edema and hemodilution. So initially, the crystalloids or colloids, they can be given to replace the blood loss in a ratio of 2:1. Till about 20% of blood loss, we can given. So the preferred fluids, they are ringer lactate and plasmolite. If the blood loss is rapid and leading on to hemodynamic instability, or after more than 20% of the volume is lost, colloids, they should be given in a 1:1 ratio. The requirement of blood, the trigger for blood transfusion, it will depend upon the age, the hematocrit, and the associated disease process. And we have to calculate the maximum allowable blood loss. Nowadays, restricted hemoglobin thresholds with a target of 7 grams per deciliter, they are adopted for children who are not ill. The children who are previously not compromised. And approximately 0.5 ml PRBC is replaced per ml of loss beyond the maximum allowable blood loss. It will achieve a hematocrit slightly greater than the target of 30. Nowadays, however, the optimum threshold is considered about 12 grams per deciliter, though the evidence is controversial. We should always look for single donor, leukocyte depleted, irradiated, and fresh blood when to replace blood in children. In the post-operative period, again, it is recommended to restart oral fluids as early as possible if there is no contraindication according to the surgery. Isotomic fluids to decrease the risk of iatrogenic hyponatremia. The American Academy of Pediatrics, they recommend if maintenance fluids they are required for children from 28 days to 18 years, then isotonic fluids with potassium chloride and added dextrose, they should be considered. So the key points of this presentation are to optimize fasting times in order to decrease the patient discomfort. We should strive to stick to the guidelines and decrease the fasting times proactively. Balanced isotonic solutions prevent hyponatremia and hyperchloremic acidosis. 1 to 2% glucose should be added to prevent hypoglycemia, lipolysis, or hyperglycemia. Colloids can be safely used to quickly normalize the blood volume in case of perioperative circulatory instability and blood loss. The trigger for blood transfusion, it is individualized depending on the age, the starting hemoglobin, and associated disease, but restrictive hemoglobin thresholds as low as 7 grams per deciliter, they can be safely adopted. Thank you very much.
Okay, thank you very much, Dr. Shubdeep. This was a nice lecture and you have elaborated quite well. The only thing is that to what, I mean, beside the water, to which you say that, which are the clear fluids, you know? Like some people used to advise apple juice or something. So what do you think that, which are the clear fluids?
Sir, besides water, glucose can be added to water. It is a very cheap solution to be kept in the preoperative area also. Mm-hmm. So we can add glucose, simple Glucon-D or something like that to water. Then the clear fluids, apple juice, as you mentioned, they have to be, the fruit juices, they should be without any added pulp. And non-carbonated drinks, they have been advised.
That is important,
yeah. Yes, they should be non-fizzy. So a real apple juice instead of Appy Fizz is the choice.
And one thing, Dr. Shubdeep, which colloid you prefer? You know, usually we don't, I mean, use the colloid as much as possible. But if it's required to replace the fluid, I mean, volume, then which colloid you prefer? You?
Sir, I would say that in my practice also, we do not use colloids in children.
Yeah, that's as much as possible.
Yes, it is crystalloids and then blood is required.
because anyway. Yeah, Dr. Pradeep. Dr. Pradeep. So any question? There is no
Sir,
question.
Sir, I want to ask, I want to share what we do at our center. I'm Dr. Rakhi. Pre-op fasting is always a major issue. Either the kids are over-fasted or they are under-fasted. And there'll always be a pressure, whether it's a government institute or it's a private. Surgeons will ask you to take the child in spite of all the guidelines. So we've started last, say about 2 years, we started doing an ultrasound also to check the gastric emptying. Of course, now I've been doing it for so long, so I can say with confidence that the stomach is empty or not. But yes, it's a good thing. If you have the ultrasound, practice more and more so that we can help in our OT scheduling in some way. So that's one. Second, during our PSC, in the last 5 years, we encourage children to have water, apple juice, coconut water, and we tell them, we give examples of the brand like Appy, non-fizz Appy, and real juice. So apple juice is nice and easily available everywhere. So they can drink that and come. So they're less hypovolemic, less hypoglycemic. So I also say, so everybody comes last two. Regarding intra-op fluid management, since last 5-6 years, I think, we have stopped calculating that 4:1 because it over and underestimates the fluid volume. So we follow the German guidelines, which is very simple. And the best part is there is no math involved. So it's 10-10-10 rule, which is quickly faster child. Just give 10 ml per kg. Multiply by 10 is the easiest math we can do. And followed by, depending on the surgery. So it's not a single event. Fluid management is a very dynamic process. When the surgeons are just cleaning, draping, there's no fluid loss. So just give 10 ml per kg per hour. When there is an incision, suppose a laparotomy, and you can see the child or the baby oozing, the gut is out, that's the time you give 20 ml per kg per hour. You corroborate with your blood pressure, with more importantly, your heart rate, how's the SpO2 pleth showing. So there's so many indicators that tell you that you have to run this fluid faster or slower. Third, choice of fluids. We routinely give either ringalactate or plasmolite. I found ringalactate to be as good. Except in neonates, we add sugar. Otherwise, no sugar to be added unless really required. So I thought I'll share some of these simple things that we've been practicing on a daily basis for now a considerable amount of time that I could share with everyone. And anything different or any questions, I'll be happy to discuss on this.
We too follow the same, Rakhi.
Yes, ma'am.
Really, you want to add anything?
Ma'am, may I just make a comment? Yeah, Dr. Rakhi, yes, we follow more or less the same. Only thing is, if the child is not adequately fasted, we give 15 ml per kg in the first hour and thereafter 10 ml per kg per hour.
Yes, sir. Yes, sir. That's what I said. If they're adequately fasted, 10, otherwise you see. So it's a case-to-case basis and not just a 4:1 rigid formula. And frankly, a lot of math is involved in it. And I find myself calculating and the surgery is done.
Usually the calculations also come down to the same thing, 15 ml per kg in the first hour and 10 in the second. Most of the calculations come down to the same thing.
Yeah, that is true.
Also, there is, I know in 4:1 gives you a sense of rigidity. as you rightly said, it's a very dynamic thing. Giving fluids is a very dynamic thing. So
Quite right, ma'am. Quite right.
Yes.
Raylene wants to say anything?
Yes.
Raylene? Okay, no problem.
I think we move on to the next topic, ma'am.
Okay, thank you very much. Please, Dr. Vishal, please carry on.
Thank you very much, sir. Thank you very much, sir. So moving on to the next topic, we have basics about the regional anesthesia by Dr. Anil Verma. And the chairpersons would be Dr. Sanjeev Palta, sir, Dr. Rakesh Garg, sir, and Dr. Tanveer Singh. May I call upon Dr. Sanjeev Palta, GC member, RSSCP, Dr. Rakesh Garg, GC member, RSSCP, and Dr. Tanveer Singh, GC member. Please welcome and introduce Dr. Anil Verma.
Thank you, Dr. Vishal. My congratulations to everybody, particularly to my Honorable President, Dr. Indrani, and the dynamic Secretary, Dr. Vishal, and the would-be President, Dr. Naveen. And what a great day to be together and hosting, kind of keeping the flag high of RSCP. And now with the permission of my co-chairpersons, I have the privilege to introduce Dr. Anil Kumar Verma, who is Professor and Head, Anesthesiology, Critical Care and Pain Medicine from Rani Durgavati Medical College, Bandra. And he has an expertise in dilatational percutaneous tracheostomy and in difficult airway management in oral malignancies. And to his credit, he has got more than 24 publications and a patent product by the name of AM Bronco Trainer. He has previously held the post of President ISA as well as President RSCP UP State. Over to Dr. Verma. Thank you very much.
Dr. Anil Verma, please.
Thank you very much. Good evening to all of you. And first of all, congratulations for the day of this RSSCP Foundation Day. And thanks for your kind introduction. Here, one topic is being allotted to me about the basics of the regional anesthesia, because when I keep on teaching my students, I always found that most of the students, they are more focusing towards the procedure, how to go for the procedure. But so many things which are also associated with this procedure that are being either ignored or somehow left by the residents itself. So I was just focusing on the teaching of to my residents about some basics and some other parameters or other component of this regional anesthesia to be taken care. So my talk will be just on the this something related to the other factors related to this regional anesthesia. So I just made a topic by the name of the basics of regional anesthesia. So thank you for the introduction. So let me start with my topic. And first of all, I start just by the basics of anatomy of this nervous system. As we know that if we talk about the regional anesthesia, we are mostly dealing with the sensory as well as the motor component of the central the nervous system. So the sensory fibers are something which arise from the dorsal root ganglia and enter into the dorsal horn at the dorsolateral aspect of the spinal cord, whereas the motor fibers, they arise from the ventral horn, and they are basically the fibers which exits from the spinal cord, that are from the ventral lateral aspect of the spinal cord. And both the fibers, they converge at the level of intervertebral foramen and continues as a single nerve to the peripheral tissues. So once they leave the intervertebral foramina, they further divides into the dorsal and ventral.
Sorry, Dr. Verma, are your slides moving?
Hello.
Are your slides moving?
Yeah, my slides are moving.
I mean, they are not. I mean, only the first slide is the title slide is visible on the screen.
Okay. Fine. Let me.
So please put your slide, this PPT into the slideshow mode. The button close to 91% down on the right side down.
Is it working now?
91%. No, it's not visible, sir. The button close to 91%.
91%. It is 91%.
The left button.
Okay, fine.
No. I mean immediately, not minus button. I mean immediately left to the 100%.
Okay.
सर ये तो आप माइनस प्लस वाला बटन दबा रहे हैं. हाँ ये वाला yes.
ये वाला.
Slideshow wala, sir.
Is it okay now?
It's not yet okay, sir.
सर थोड़ा सा ये जो आपका जिसपे आपका टाइम बना हुआ है ना, टाइम फॉर्मेशन में नीचे
जहाँ पे 3 बटन
that button, जहाँ पे 90% लिखा हुआ है, 90% के बाजू वाला,
हाँ ये वाला,
दबाइए सर,
हाँ दबाइए सर।
हाँ इसको तो कर रहे हैं, लेकिन उसके बाद आपके पास स्लाइड शो नहीं आ रहा है। Is it
You
working
press
now?
that button once again.
I think you need to close down this window and reopen it again, sir, please.
Okay, good.
You need to share it again, looks like, you know.
Close the window, sir.
You have to stop sharing and then start sharing again.
Just wait.
Start sharing again, sir.
Oh, let me reconnect it.
Okay, please.
Okay.
I think sir will take a few minutes to reconnect.
No, what I feel is let him make it 90% and let him continue. So we'll ignore the left side, I think.
Ma'am, actually the slide was not moving.
No, I think with that it was moving.
Dr. Anil Verma, sir, can you hear us?
Later on, it started moving.
Started moving, that's why.
Yeah.
So if he is not able to give a full screen, it's fine. We just keep moving. Yeah.
Actually, ma'am, I think he has logged out and he's trying to reconnect.
Okay, doesn't matter.
It'll just take 1 minute.
No problem.
I think, ma'am, in regional anesthesia, everybody is talking about segmental anesthesia nowadays. Hello.
Yeah.
Hello.
I think everybody is talking about. Sir, are you there, sir?
Yeah.
Yeah. Okay.
Please share your screen, sir.
Yes. From where to share? Share screen.
Press the green button, sir. Share screen.
You need to. You have
lower...
disabled. You have disabled participation.
Oh, just wait. Yes, sir. Now I have enabled you. Please share.
Is it visible?
Open up the. Yes, sir. It's visible. Put it into the slideshow mode.
Slideshow.
Doesn't matter, sir. Press on the second slide.
Is it working?
It's not working, sir. Present.
Not working. Go to the second slide, sir.
Yeah, I've gone to second slide.
Oh, it's not moving.
Sir, which laptop you are using?
Microsoft Pro.
Okay.
Sir, go on to the slideshow key on the top, sir. Go on to the slideshow key on the top. Home, insert, design, animation.
I'll give you a suggestion. What you can do is you stop sharing this one.
Now it is moving, ma'am. Now it is moving, no?
Is it moving? Yeah, it's moving. Now it is second.
Okay,
Yeah, it's moving. It's moving.
Yes,
Please
it is
go ahead.
moving.
Please go ahead, sir. It's moving.
Okay. Should I
Yes,
go
sir.
for the
Yes,
slide
sir.
show?
Yes, sir. Yes, sir. Please.
Okay, it's moving now.
Yes, sir. It is moving.
Okay, fine. So
if you can just make it a full screen.
No, that's okay. It's not able to do it. It doesn't matter.
Doesn't matter. It is
Okay,
moving.
Okay, so again, I am starting my talk, and because my talk is basically focused on the teaching of students, because many times the students are more focused on the procedure itself, but they forget about the different component of the regional anesthesia. So this talk is something basics about the regional anesthesia, what they do, they should understand before performing any procedures. So first of all, I discuss about the fibers, because in the regional anesthesia, we are basically focused on interrupting the signal transmission or conduction through the sensory fibers, as well as we also block the motor fibers. And the sensory fibers are the fibers which basically enters into the spinal cord through the dorsolateral aspect, and it arises from the dorsal root ganglia, whereas the motor fibers are the fibers which come out of the spinal cord from the ventrolateral aspect and reaches to the effector cells. Both the fibers, they converge at the level of intervertebral foramen, and after that they divides into the ventral and dorsal rami, where the dorsal rami, they basically supplies the muscles of the back as well as skin of the back, and the ventral rami basically they forms the plexus and supply the muscle as well as the skin, different organs of the abdomen, pelvis, and the limbs. So if you see the gross structure of our nerves, that contains the axon, which is the basic nerve fibers, which comes along with each other and form the which are covered by the endothelium. Later on, they get collected in a bunch and forms the fascicle, which is covered by the perineum. Then fascicles comes into the becomes bunched up, and they later on form the nerve fibers. Nerve fiber. So to block any nerve conduction, that is not simply to block the nerve at a single point. It won't work. So to block any conduction, we need to block a segment of the nerve. Whereas because we very well know that myelinated fibers, the conduction is on the saltatory movement. There are nodes of Ranvier where the conduction jumps from one nodes of Ranvier to another nodes of Ranvier. So conduction won't be blocked until we block more than 3 nodes of Ranvier. So if the small amount of drug is being used and less number of nodes of Ranviers are being blocked, then there will be no total conduction block through the myelinated fibers. Whereas in the non-myelinated fibers, there is no myelination, and the sodium channels, which are the most important channel where the local anesthetic work, are dispersed.
Verma sir, sorry to interrupt. The slides are not still moving.
Oh. Not moving again?
Not moving.
Okay, let me come out
Go
of
to
the
next slide, sir.
slideshow.
Go to next slide. Just now they are moving, I think.
Okay. So I should stop slideshow. I should continue with the same without slideshow. Probably in this mode, it's moving.
Yes, sir. Yes.
Is it? Okay.
Yes, sir. It's moving now.
Okay, fine. So when we go for the conduction block, we need to block a segment of the nerve fiber. It is not simply a single point where we just block a nerve and the conduction will be blocked. In case of a myelinated fibers, because the conduction is on the saltatory movement basis, so more than 3 nodes of Ranvier to be blocked. Unless until we block all the 3 nodes, the conduction will still be continuing. But in case of a non-myelinated fiber, where there is no myelination and no nodes of Ranvier, the sodium channels are dispersed throughout the nerve fibers, and because the sodium channels are very dispersed throughout the surface of the nerve fibers, so these nerve fibers are relatively resistant to the local anesthetic action. So, and they need a longer segment to be blocked, and more dose is required for the blockade of unmyelinated fibers. So if we go for the regional anesthesia is most commonly used by the pain physicians as well as the anesthesiologists for the purpose of surgery and the post-operative pain management. So we should, when we think about the regional anesthesia, we should have knowledge of the nerve anatomy, which we have discussed in brief, and about the drug and its toxicity, and certain equipments like nerve stimulators, needles, and ultrasounds, and few of the additives which can be combined with the drugs to improve the potency, the onset of action, as well as the duration of action. So rather just simply learning the different procedures to block the nerve, we should also understand these components of the regional anesthesia. So theoretically, if we plan at any type of block, we should understand the various dermatomes, myotomes, and osteotomes. So dermatomes, that is the skin supplied by the dorsal root, but the C1, which doesn't supply any dermatome. Myotomes, the muscle supplied by the ventral root, and osteotomes, it is entirely different from the dermatome as well as myotomes, and it doesn't correlate with the dermatomal as well as myotomal supply. But for all practical purpose, we should not very much worried about these dermatomes. We should be more focused on what type of surgery and where to incision to be given, and which particular block can cover that area. So if we just look at this diagram, the various dermatomes has been shown here from C1 to S2 levels, and similarly the dermatomes shown here from the back. Now I will just try to focus my presentation more on the upper limbs. So I will explain on the basis of upper limb. So this is a picture of the brachial plexus, where the brachial plexus arises from the ventral rami from C5 to T1, and it comes between the anterior and middle scalene muscles. So if we go through this diagram, the various ventral rami join to form a trunk, then again the roots are joined to form the trunk, then divisions, then cord, and then various nerves and ends up into the terminal nerves. So this is the dermatomal presentation, where the sensory nerves supply the various dermatomes, like the supraclavicular nerve, which supplies near the shoulder, then the axillary nerve, which also supply the skin over the shoulder, then the inferior lateral cutaneous nerve, the lateral brachial cutaneous nerve. These are all the dermatomal presentation, how the dermatomes are being supplied. Now let us go towards the basic anatomy of the brachial plexus. So before going for the blocking any component of the upper limb or any component of the brachial plexus or distal nerve, we should understand where we want to put our drug, inject our drug, and what particular dermatome or the nerves will be anesthetized. So we basically practice for the 4 different level of the blocks in case of a brachial plexus. That is the interscalene, which is the block basically near the roots, the supraclavicular block, which basically blocks the trunk, the infraclavicular and block, and the axillary block, which basically blocks the cords as well as the distal nerves. Where that this infraclavicular and the divisions as the cords, these blocks are around the clavicle. If we just inject the drug just above the clavicle, that basically blocks the divisions, and just below the clavicle, it basically blocks the cords. So when we go for the interscalene block, it is basically indicated for the shoulder surgery. So whenever there is any surgery to be performed on the shoulder, we should always prefer the interscalene block. And it always spares below elbow, basically is the area which is supplied by the ulnar nerve. And the main most common complications, we should understand always that phrenic nerve is involved. So it is contraindicated specifically in the patients who are suffering from any respiratory distress like COPD and any respiratory complication. So we should avoid these blocks, because phrenic nerve involvement will affect the diaphragm movement. Now the supraclavicular block, it basically it is indicated for any surgery on the upper limb, but still it spares the medial aspect of the arm, which is being supplied by the intercostal nerve. So the complications are same as in cases of interscalene block, but an additional complication which may be there, like that the injury to the pleura and cause the pneumothorax. Again, the respiratory, if the patient is suffering from any respiratory distress or any respiratory disease, then we should try to avoid this supraclavicular block. Infraclavicular block, it is mainly indicated when the surgery to be conducted at the elbow level or below the elbow level. All and most of the part are above the elbow level are being spared by the infraclavicular block. And the common complications which may happen with this blocks are pneumothorax, chylothorax, pneumothorax, and maybe intravascular injections in this case. So, and the problem with this block, when we even practice this block with the help of ultrasound, the most of the structures are difficult to visualize. So this block is not very much practiced by the anesthesiologist. Now, another block is the axillary, specifically axillary block with musculocutaneous block. And this block is indicated for all the surgeries below elbow and hand. The sparing is elbow and above elbow. And the most common complication is the vascular injury, and it is considered to be most safer than any of the above blocks. So unless until we understand the where the surgery is to be conducted and which block is to be preferred, then there are most common chances of choosing a wrong block for the wrong patients. So this is this is the basic presentation of the dermatomal or the analgesia or the area which is covered by the supraclavicular block. And with the supraclavicular block, because the intercostal, because the medial aspect of the arm is spared, so to cover that core component of the arm, we need to give the intercostal brachial nerve block, and this block is given simply by the skin infiltration at the medial portion of the arm. Now the individual peripheral nerves can be blocked, like the ulnar nerve, the median nerve, and the radial nerve. These are the dermatomal presentation. How this individual nerve block works. For the ulnar nerve, the medial aspect of the hand on the dorsal as well as the ventral aspect, whereas the median nerve that covers the medial lateral component of the surface of the palm, the 3 digits, and the distal portion of the thumb, and simply on the digital portion of the distal digits of on the dorsum of the hand. And similarly by the radial nerve also, this is the presentation is shown here. So what are the specific spared area when we talk about, when we go for the shoulder surgery? The shoulder surgery, the preferred brachial block which is to be preferred is the interscalene block, but still the shoulder is not completely covered by the interscalene block. So because the anterior surface of the shoulder is being supplied by the C1 and C4, for that superficial cervical plexus block is to be given, then only the shoulder surgery can be conducted. And the second is sparing by the brachial plexus block in case of a supraclavicular, that is the medial surface of the arm covered by the intercostal. So this is the supply of the shoulder, which are which is supplied by the various nerves, that is the lateral pectoral nerve, suprascapular nerve, subscapular nerve, musculocutaneous axillary, and axillary nerve. So when we want to conduct any surgery over the shoulder, along with the interscalene block, we need to give the suprascapular nerve block additionally, so that we can cover the most of the component, which is most of the nerves which are supplying to the nerve or shoulder. Now, when we plan to give any block according to the surgery, and we have planned what block is to be preferred and what could be the sparing and what additional supplemental block are to be given, then we also need to take care of the contraindication, which where we need to avoid this regional anesthesia. That is one most common complication, most common contraindication is coagulopathy or infection at the site of injection or any injury to the site of injection. Because if in case of orthopedic injury where the fractured clavicle as well as the fracture of the shaft of humerus both are there, and we want to conduct surgery on the shaft of humerus, and we plan for the brachial plexus block, but due to the fracture of level there may be distorted anatomy of the brachial plexus, and we may injure some vital structure, or sometimes the drug may injure nerve as well as the intrathecal extension of the drug can be there if there is any injury. So, and the most important contraindication is the patient refusal. So if the patient doesn't want that regional anesthesia to be given, it should never be given. So when we go for the regional regional anesthesia, we should always explain the procedure to the patient, which most of the time the reasons forget to do. So all the benefits of the block, what the patient will have, and what are the risks and what we expect from the block. Because many a times when we give block to the patient and the expectation of the patient is more, then patient may be dissatisfied or may not cooperate and accept that. Second, once we have explained about the procedure to the patient, then while going for the block, always identify the site of the surgery as well as the landmark and the structures which are where according to which the block is to be given. So I'm not going to explain the procedure of the block. So I'm just picking up the points out of that procedure. So when we start, when we plan for the block and we insert the needle to the for a particular block, we should always aspirate before injecting any drug. Because if we talk about the complication specifically for the supraclavicular block, there is a transverse, there is a vertebral artery. If it is even a small amount of drug is injected into the vertebral artery, it will immediately produce seizures because there is it is a shortest because the direct drug is injected to the cerebral circulation. And if the seizures are because of the systemic toxicity, it is never by the small amount of drug, and it takes time. So if there is any immediate seizures and with a small amount of drug, immediately stop, and there are very high probability that we might have punctured the vertebral artery. If we are using an equipment like ultrasound, then probe should always be placed in a manner so that the nearest vessel is seen in that ultrasound image is completely circular. So that is how we hold the probe and place the probe. Unless that vessel is not complete circular, that means we have our probe is tilted, and it may not produce the appropriate image of the plexus as well as the surrounding structures. When we inject the drug, around the nerves, we should always see the nerves are floating and the drug are properly surrounding the plexus as well as the nerve. Now, what are the benefits of the ultrasound? It is always considered as a standard of care, and it provides a better duration and intensity of block because the drug is injected around the nerves under vision, and most of the roots or most of the nerve component of the plexus are being covered and well surrounded by the drug, and better satisfaction of the patient, surgeon, as well as the anesthesiologist. Now, another component, how to choose your local anesthetic, that depends basically on the two factors. First, what speed of onset of the anesthesia we want, and how much the duration of action. If we see the chemical structure of the local anesthetic, it has an aromatic compound. It is an aromatic ring, and ester or amide linkage, and the amine end. So the aromatic ring, which basically decides the lipid solubility, and more the lipid solubility or more the molecular size, it will be more potent, and the duration of action will be more. So the aromatic end of the local anesthetic that decides the potency as well as the duration of the effect of the drug, whereas the amine end of the molecule that decides basically the water solubility. So if the drug is more water soluble, it can easily attach the sodium channels. So every drug has a one component, either the higher molecular weight or higher lipid solubility or more water solubility. So, and another component which is very much important, the differential block, specifically when we want to give only the sensory block. The drugs, specifically the bupivacaine and ropivacaine, they shows the differential block. And the short acting as well as the rapidly acting drugs, they don't show the differential block. They have no difference between the sensory and the motor block. So while choosing the drug, we should first decide what component of anesthesia we want, whether we want the motor as well as sensory both, or we want simply the sensory block. So the bupivacaine and ropivacaine, if we reduce the dose, there are more sensory block is there. If we increase the dose and concentration, the sensory as well as the motor block, both components are present. So the linkage, the ester and amide, that basically decides the method of metabolism. So most of the esters they are metabolized by the pseudocholinesterase, whereas the amide are metabolized by the liver. The amide local anesthetic, which are mainly metabolized by the liver, are also affected by the beta blockers, H2 blockers, liver failure, and heart failure. So the patients who are on the beta blockers or taking the H2 blocker from the long time, or liver failure, heart failure, the action or duration of action of these drugs are being prolonged. Few of the local anesthetic, they may cause the methemoglobinemia like benzocaine, procaine, and prilocaine. Out of it, we sometimes use the prilocaine as a surface anesthetic, not given parenterally. The other factors which may influence your block, that is what is the site of injection, because few of the sites of injection where the blood supply is very much high and rapid washout of the drug is from that site, so the overall duration of action is smaller. Dose and volume. So overall duration of the block is also depends what are the concentration and total dose of the drug is being given. In pregnancy, because the pregnant females, they are more sensitive to the local anesthetic. So the dose, overall dose may be required to reduce. In case of a pregnancy, temperature also affects the overall duration as well as onset of block. The pH specifically, sometimes we add soda bicarb, which helps in the early onset of the block, and the concept behind it, because the non-ionized drug only penetrates the membrane of the nerve fibers. So when we add the soda bicarbonate into the local anesthetic, it increase the non-ionized form of the drug, which easily penetrates inside the drug, and early onset of the effect is there. Few of the additives, they also affects the duration as well as onset of the block. Few of the preparations like liposomal and right to left shunt, that increases the overall duration of the effect, as well as it also increases the toxicity of the effect, because most of the local anesthetic agent, they get metabolized in the lung. So if there is right to left shunt, so this component of the metabolism, which is in lung, is bypassed. So if you see the toxicity component, how the toxicity to be detected, if accidentally it happens, there is a mnemonic that is SAMS. S stands for the slurred or difficult speech, A stands for altered central nervous system, M for muscle twitching, and S for seizures. So if you see the toxicity, specifically the cardiovascular, cardiovascular toxicity is always produced with the dose, with the 3 times of the dose required for the seizures. That means if the cardiac toxicity appears, that means we have injected excessive amount, because the seizure comes, the neurotoxicity, the seizure comes 1/3 of the dose required for the cardiac toxicity. And the cardiac toxicity, the cardiac sodium channels bind to the local anesthetic more in case of a bupivacaine than lignocaine. That's why the bupivacaine are more cardiotoxic than the lignocaine, whereas the S optical isomer, that is levobupivacaine and ropivacaine, they have a less affinity for the sodium cardiac sodium channels, so they are less toxic than the conventional bupivacaine. When we give this local anesthetic on the higher dose, they not only gets attached to the sodium channels, but also gets attached to the calcium channels. So not only they are affecting the conduction of the heart, but they also affects the contractility and the muscle activity of the heart also. So neurotoxic effects, they are in the form of vertigo, tinnitus, perioral numbness, tremors, myoclonic jerks, convulsions, coma, and ultimately the cardiovascular collapse. So how to manage this local anesthetic toxicity? So if we know how to manage this local anesthetic toxicity, we can be prepared. We can always be prepared with the emergency cart in the operation theater, or wherever the place wherever we are planning to give this regional anesthesia. It is by the mnemonics of ACLS SLE, where the ACLS stands for the cardiac life standard cardiac life support, advanced cardiac life support, where we can give the oxygenation, and if the respiration is compromised, then back mask ventilation, or by securing the airway and mechanical ventilation we can go for. Low dose epinephrine can be given, but in case of a bupivacaine toxicity, sometimes epinephrine may further enhance the possibilities of arrhythmia. So in that case, vasopressin could be a drug of choice. Always avoid the calcium channel blocker and beta blocker in these cases. And amiodarone is one option to prevent the arrhythmias in case of a local anesthetic toxicity. S stands for the seizure suppression, and the drug of choice for the seizure suppression is benzodiazepine. Propofol, if benzodiazepine is not available immediately, then propofol can be used. But if benzodiazepines are available, always prefer benzodiazepine in that case. Lipid emulsion is considered to be the treatment of choice in case of a toxicity, and 20% intralipid should always be in hand, and the dose which has been given, that is 1.5 ml per kg body weight in 1 minute, and then 0.25 ml per kg body weight per minute for 30 to 60 minutes. And if patient still doesn't respond to the therapy, then last option is the extracorporeal membrane oxygenation. So this is are the NICOLA guidelines. where regarding the lipid emulsion, if the patient is of more than 70 kg body weight, then bolus dose of 100 ml over 2 to 3 minutes, and later on infuse the 200 to 250 ml over 15 to 20 minutes, and reassess the patient. If the patient remains unstable still, then we can repeat the dose, repeat this bolus as well as the infusion again. If the patient is less than 70 kg, then bolus dose is 1.5 ml per kg body weight for 2 to 3 minutes and 0.25 ml per kg body weight per minute for the patient. And patient doesn't respond, then we can repeat the therapy. Now we should also understand something about the nerve stimulator, which is the equipment used during regional anesthesia. In for the use of this nerve stimulator, there should be an initial setting. So just a brief about the nerve stimulator. Nerve stimulator is a device which helps in the detecting of the proper placement of the needle, whether it is in close proximity to the nerve or plexus or not. So if we always start up with a certain setting with the formula of 2, the 2 milliampere, 2 hertz, and 2 milliseconds. So when we start with the ampere, the muscle twitch is where we don't inject drug unless the muscle twitch is present with the less than 0.5 milliampere. And when the muscle twitch is present with the less than 0.5 milliampere current, we stop further proceeding in the needle. If the current, so withdraw the needle at least 1 millimeter away, and a small amount of local anesthetic to be injected, but we be assured that the injection pressure should not be more than 15 psi. These peripheral nerve stimulator doesn't work when the muscle relaxant are being given, but they work very but these peripheral nerve stimulator works even if the neuroaxial blocks are being given. So there is a standard setting. How do we start? That is from the current from 1 to 1.5 or 2 milliampere. That can be standard setting with the 2 hertz and 2 seconds. And when the muscle twitch starts visualizing, just reduce the current and proceed further insert the needle unless until we perceive those muscle twitching at 0.5 milliampere or less. If the muscle twitch are found even below the 0.3 milliampere, that means we have our needle tip is inside the nerve sheath. We need to withdraw the needle. Now something about the additives. There are a few additives because the quality of block is always on the base of the onset, the potency as well as the duration. And if we want to improve the potency, duration as well as the potency of the drug, then we can add certain additives. So many of the additives are being tried. Out of that, few are here like opioids, because these opioid receptors are basically found in the dorsal horn ends. Whenever there is any injury, these receptors migrate through the nerve fibers to the peripheral. So this migration takes some time. So it takes around 96 hours to reach to the site of injury. So the analgesic effect due to opioids may take time. So what these opioid drugs do, when the opioid receptors at the site of injury, and we give opioid either systemic or local, they activates the inhibitory G protein that suppresses the calcium and sodium and further inhibits the current transmission. So like this, they provide the analgesia. So most of the preferred opioids which are being advised to use for the in the regional anesthesia are buprenorphine as well as the tramadol, because buprenorphine has 25 to 50 times more affinity for the mu receptors in the peripheral block. Tramadol also inhibits the uptake of norepinephrine as well as serotonin and like this they inhibit the neurotransmitter, which are the neurotransmitter for the inhibitory descending neurons. So if the tramadol inhibits the uptake of norepinephrine in the spinal cord as well as the serotonin, so more amount of inhibitory neurotransmitters are available, so they further reduce the conduction of the pain sensations. Alpha agonist is one more additive which can be used. The clonidine, which can be used in the dose of 1 mics per kg, and these alpha receptors are found in the dorsal root ganglia. They inhibit the presynaptic release of excitatory neurotransmitter, that is substance P and the glutamate. They also increase the release of the acetylcholine that stimulates the muscarinic receptor and causes release of inhibitory neurotransmitter gamma amino butyric acid. Dexamethasone can also be used in the dose of 4 to 10 milligram. It has direct anti-inflammatory effect and also reduce potassium channel mediated ectopic neuronal discharge. One more group of drug which can be used, that is NMDA receptors, and among this NMDA receptor, the ketamine and the magnesium, two drugs are can be used. The ketamine dose of a 0.5 milligram per kg and magnesium 25 to 100 milligram 100 milligram, and they are still under study because the complication and side effects are still not sure what can be there. So this is the chart of various additives and the complications, the side effects, whereas the NMDA receptors are still under study. The various doses of this opioids which can be used intrathecal or opioids like morphine in dose of 100 to 200 mics intrathecally and 1 to 5 milligram, epidural fentanyl 10 to 25 mics, intrathecal 1 to 2 mics per kg in case of epidural, tramadol 10 to 50 milligram intrathecal and 1 to 2 milligram per kg epidural, clonidine 15 to 40 mics intrathecally can be given, and in epidural 25 to 50 mics per hour in case of infusion, though it is not a method of choice, and peripheral blocks 0.5 mics per kg it can be given. Dexmedetomidine 5 to 10 mics in intrathecally, whereas 1 mics per kg epidural, and in peripheral blocks again 1 mics per kg body weight can be given. Dexamethasone 4 to 8 milligram intrathecally and 8 milligram epidural, and 4 to 8 milligram can be given in peripheral blocks. Midazolam is also tried, but the complication is sedation and respiratory depression, so it is not highly practiced. So, thank you very much.
Thank you, sir. It was the most simplified presentation, and I'm sure the residents whoever are listening over here must have got enriched. Now I may request my co-chairpersons to please initiate the discussion.
Thank you so much, sir. Congratulations, Professor Verma, for a nice listed talk. Can you just share your experience? Dr. Vasantha also, ma'am, wants to ask, do you have your personal experience for the beneficial effect of lipid emulsion in cases of local anesthetic toxicity? Because we know that evidence is sufficient enough. But does it really works in your clinical experience?
Actually, sir, I am fortunate enough that I have not seen local anesthetic toxicity in my setup. But because whatever I can share, that is all about all whatever mentioned in the literature, because we don't have any other drug right now till date which can be used as an absolute antidote for the local anesthetic toxicity. So still, we have no option left other than using this lipid emulsion.
I think you're right, because maybe we are using more of an maybe earlier days the nerve stimulator, and nowadays more of ultrasonic guided techniques where we have come down with the doses, and also we are very sure that we are not giving any intravascular drugs for these. I think that will be the probable reason could be useful. The one other question that has come is we have a lot of adjuvants that are available. And many of these adjuvants are not approved for their intrathecal or along the nerve plexus or along the nerve use. But the research has found that to be useful. Like, for example, say dexmedetomidine. There are a number of studies which they have found useful. But sometimes they, even as older drug like neostigmine, they have been used. So what do you suggest to us as the audience that among the armamentarium of various adjuvants, which we should use it in a clinical practice, and which of these group of drugs are purely for the research purpose and from medical legal aspect, we should be a little cautious in documenting them appropriately?
Actually, there are a few of the literature which are which are also already in favor of using of opioids intrathecally, like fentanyl and even morphine. Though we have a little bit more neurological complications with morphine, so fentanyl is considered to be quite safe and good. Whereas in case of alpha-2 agonist, dexmedetomidine is still under trial and off-label used. Though we have found very good efficacy of the for enhancing the duration of analgesia intrathecally as well as epidural. But if we just want to know from legal point of view, from ethical point of view, still, I think the dexmedetomidine cannot be used, but clonidine still, yes, in favor of clonidine, it is few of the articles are there, intrathecal use. So I use clonidine basically intrathecal.
Yeah, I think many of the participants are also mentioning that they have used it regularly, and I think various studies have found that they will prolong the sensory analgesia aspect, and probably it will reduce the dose requirement also, and they're useful. But just a word of caution, because many of these drugs are being used as non-indicated drug and dosages. So we should be a little cautious when we are using them into our clinical practice, because they have not been approved for this purpose. In research, because we are taking consent and we are explaining everything, so it's fine. But for routine clinical use, we should be a little, I think, comfortable. Maybe if any of us are well versed with the drug controller, we can try to expand their dose and route. Otherwise, it remains a drug which is for experimental purpose also. Everybody is appreciating your nice talk, Professor Verma.
Rakesh,
Is anybody using?
Dr. Rakesh, there is a question, and the last the chat is it ethical if not approved?
I
no,
think
it
this is yeah, Professor Verma, to you.
Actually, ethical and unethical, they have I think my personal opinion, they have two different dimensions. One is whether it is ethical in favor of a patient, society, and for the benefit of the patient. Another dimension is whether we can save ourselves legally if something happens wrong with the patient. So if we talk about the legal component, legal dimension, then definitely, unless until we have enough amount of literature in support of these drugs, we should avoid using them. If we talk about the another dimensions for the benefit of the patients, though we have enough experiences, all of us, and worldwide experiences in favor of benefit, then it is again a situation whether you can get your patient convinced for using that drug or not. That is entirely different thing. Otherwise, research has to be awaited further.
Nice.
I think nicely summarized, but I think one comment which is coming in the chat box is equally important, because if we see many of these adjuvants that are being used as a part of various nerves and blocks, we usually are targeting the short-term outcome, which is the duration of analgesia or duration of motor block or the decreased requirement of opiates. But majority of these adjuvants, the long-term sequelae or long-term outcome has not been studied in many studies. And actually, we do not know. That's why, and that is the probable reason, because when a drug is approved for a particular indication, it should prove the short-term and long-term safety profile. Short-term safety profile, enough. So as Professor Verma said, they should not be an ethical issue because they have been proven into various studies. Whether when we're talking about the legal issues and other concerns, majority of study, majority of data is not talking about the long-term implications. Like for example, in the previous session also, and we have been discussing in pediatric section, the patient who received multiple general anesthesia during the infancy phase, and they are not taken care of the pain adequately, they have issues with the developmental disorders. Now we have data for it. So I think each one of us can take this initiative. Those who are using these local these adjuvants quite frequently, why not to have and say 1 year, 5 year, and 10-year data from these blocks, and let's publish. This will be a good data that will be from the, I think from RSCCP can be submitted across various multicentric studies, and that will probably help the DGCI to approve these drugs through the various routes.
Sir, the most important thing, sorry, sir, may I speak?
Please.
Yes, please.
Sir, the most important thing is that nowadays we are using ultrasonography guided blocks. They are extremely specific for they are just being given around the plexus of the nerve. So the use of these adjuvants recently, they are getting reduced actually, because we are getting targeted towards the nerve roots more closer. So they are giving a denser block along with the PNS guided. So the use of these adjuvants is actually getting reduced because we are getting a long-standing block with single use of the drugs.
That's perfectly, Dr. Masan. I think you have raised a very important point. that the ultrasonography has increased the success rate. This is one. Second, the need of adjuvants and other rescue analgesic is decreased down. This is second. And third, the most important, which Professor Verma also mentioned, the dose requirement has come down. Like for example, say brachial plexus, conventional technique, we're using 35 ml. With now stimulator, we came down to 25 ml. Now with
Now we are
ultrasound
using
guided
18,
brachial
20
plexus,
ml.
exactly. And moreover, when we are using blocks now, since we have catheters also, and we can check the correct placement of these catheters also. So probably the complication rate has come down. The last, which we have just talked about the toxicity. I remember 15 years back, we used to see 1 or 2 patients will show oral tingling. But recently, I don't find any patients will even complain of oral tingling. Ultrasonography should be an integral part of the additional block, yes, which is now coming up, and it will come down. It will require the research of the appropriate adjuvants in these things, so that we can even come down with more quantity of these drugs with prolongation of sensory anesthesia, which is being used for this. So, any more comments or any more suggestions we can have in the chat? Yes, sir.
Sir, recently we were giving brachial plexus block interscalary route. So we were just focusing on the ultrasonography, and we realized that the solution is spreading. So we changed the position of the needle. We gave the further volume of the drug, blocked lateral splenic nerve palsy. So we immediately put up an LMA, but the patient recovered in a span of 20-30 minutes.
Okay.
So that is the advantage of using a single drug. If we would have been using any kind of adjuvant with it, it would have resulted in a...
That's true. I think ultrasound has many benefits. I think the time is, we can say the time is yet to say that it has to be all ultrasound guided nerve blocks, and with various workshops and everything is happening, I think it's useful tool. I will request Dr. Tanveer Singh to just put up a concluding remark for this session.
Sorry to extend. Sorry.
No.
It was a very nice lecture, sir. One thing I would like to ask everyone here, what we are doing for the, what is your take on anticoagulants and antiplatelets when we are using for the blocks, maybe superficial or deep, when we are using ultrasound for these patients? What should
Actually,
be the?
Sir, actually, sir, if we talk about the anticoagulants and antiplatelet drugs, if we are going for the superficial blocks, I don't think there under vision. Then I don't think there any need for holding those antiplatelets or anticoagulants. If we are going for the deeper block, still if we are putting those, we are giving those blocks under vision, and we are very much aware about the anatomy, and we can spare the vascular injury with the needle, then we can put the block. It is simply just like putting a solution within a space, a facial plane. The problem is if we injure any vascular structure. If we are not injuring any vascular structure, then I don't think there is any harm for giving any peripheral or ultrasound guided blocks.
So Tanveer, absolutely. So if you're using an ultrasound, it does not alter the guidelines. So irrespective of whether we use ultrasound or we use it without an ultrasound for a block, so the guideline remain the same for superficial and deep. And it is very clearly given in the recent ESRA guideline 2022. So superficial blocks, you don't need to worry. For deep blocks, yes, you will have to customize as per the anticoagulant in use. So since your question was regarding ultrasound, so it actually doesn't help either way. It is suggested we should use ultrasound, but it doesn't mean we can give a deep block with an ultrasound with patient with anticoagulant ongoing, and which is not stopped in time.
Yes, exactly. DISORA as well as ASRA guidelines both refer to the same thing. There is no guidelines as such regarding without anticoagulation and with anticoagulation with ultrasonography. We have to be careful with both. We are introducing a thicker needle when we are giving ultrasound guided block.
So I think due paucity of time is quite an interesting discussion, but I think with paucity of time we'll move ahead. Thank you, Professor Verma, for such a comprehensive session. And I will hand over the session back to Dr. Vishal Singh.
But I think one take-home message for the students have to be there, that whether it is ultrasound or no ultrasound, you have to follow the guidelines.
Absolutely right.
Yeah.
Absolutely.
As of now, at least, let some multicentric studies come up and say that, you can use ultrasound and if you're careful and all that. So, but all that is not there as of now. So whether, you're using ultrasound or no ultrasound, we have to follow the anticoagulation guidelines for regional anesthesia blocks.
Multicentric trial are going
Very
on
important.
in Europe.
Thank you. Thank you.
I think from teaching point of view, ma'am, point is absolutely very important, because when they have to speak in exam, when they are the novice learners, I think we have to follow some guidelines, because they have been based on certain evidence. And once somebody become experts, I think they can think of some deviation. But for message on an academic platform, please follow the guidelines and monitor the patient and follow them appropriately, so that we are not missing even a single complication, or we are not doing something which is we will not be able to justify.
True. Thank you, everybody. Thanks a lot.
Thank you, sir.
Over to Dr. Vishal, please. Thank you.
Nice discussion indeed, sir. And moving on to the next topic, we have complexities of the premature infant by Dr. Parul Jindal from Dehradun. And the session would be chaired by Dr. Major General Navdeep Sethi, sir, and Dr. Sarbris Vaika, ma'am, and Dr. Mayank Masan. Dr. Major General Navdeep Sethi, sir. Please, sir.
Yeah, hi. Good evening, ladies and gentlemen. I hope I'm audible, Dr. Vishal.
Yes, sir, you are very much audible, sir. Please go ahead.
Okay.
Sir,
Yeah,
I would
yeah.
soon...
Yeah, good evening, ladies and gentlemen. And I, along with my co-chairpersons, Dr. Sarbris Vaika and Dr. Mayank Masan, welcome you to this challenging topic in the evening. Dr. Parul Jindal would be telling us about complexities of the preterm neonate or the preterm infant. Now, prematurity, that is less than 37 weeks of gestation, or extreme prematurity, that is less than 28 weeks, is always challenging for the anesthesiologist, not only in the perioperative period, but also in the NICU. Well, be it the small size of the baby or the still developing organ systems, or the complications they have a propensity for, apnea, apnea of prematurity, then respiratory distress syndrome, bronchopulmonary dysplasia, NEC, intraventricular hemorrhage, neonatal sepsis. The list is long and daunting. I'm sure our learned speaker will address the majority of these issues, as well as add to our knowledge base. So without further ado, I would like to invite Dr. Parul Jindal, who is a professor in the Department of Anesthesiology at HIMSS Dehradun, and she has an impressive CV. Besides, she has multiple publications and is the president-elect of IS Uttarakhand State and President Dehradun City Branch ISA. Dr. Parul Jindal.
Thank you so much, sir. Dr. Vishal, could I share my screen, please? Could you enable me to share my screen?
Just hold on.
There are lights.
Yes, ma'am, you can now share your screen, ma'am, please.
Oh. Okay.
Is my screen visible?
Yes, ma'am, it's very much visible.
Yes.
Thank you so much, respected chairperson, Dr. Indrani Hemant ma'am, Dr. Naveen Malhotra, sir. Dehradun was proud to host the RASPCon 2014, and I bring greetings from Dehradun. So my topic today is problems with prematurity and anesthetic consideration in such patients. On the right side, which you see, it's a preemie baby. I was called around, I was at AP and I was called around at midnight to come and intubate a baby who was born at 6.5 months. And this child weighed around 900 grams. We followed this child throughout her journey. And today this beautiful lady is 14 years old and she's doing extremely well in all her endeavors. So what will be the learning objective today in my talk will be the introduction, a brief introduction. What is a preterm baby? What are the physiological handicaps these children have? What will be the anesthetic consideration? Do they come to the OT theatre to us? And some of the landmark studies if the time permits. So what is the definition of a premature child? We actually depended upon the gestational age because this determined the extent of physiological immaturity. Less than 37 weeks is a premature and less than 28 weeks is an extreme premature. Nomenclature based on the weight will be less than 2.5 kgs is a low birth weight baby, less than 1.5 kg is a very low birth weight, and less than 1 kg is an extremely low birth weight baby. In India, the incidence of having a preterm baby is as high as 10 to 12% as compared to the West where it is 5 to 7%. The surgical conditions which require anesthesia in a premature baby could be a PDA ligation, laparotomies for necrotizing colitis, for reanastomosis of bowel or relief of adhesions, inguinal hernia repair, fundoplications, and vascular recess. Laser surgeries or vitrectomy for retinopathy of prematurity, CSF drainage, and CT and MRI scanning. Most of these kids land up for premature delivery if the mother has a maternal diabetes or a hypertension, multiple pregnancies. It could be idiopathic, it could be a placenta previa or premature cervical dilatation or cervical insufficiency. Now, how do you identify a primary? The primary can be identified with a head circumference of less than 33 centimeter and the head circumference is generally more, 3 centimeters more than the chest circumference. The child may not have a lot of subcutaneous fat. The fontanelle will be large and sutures will be well separated. There's no elastic recoil of the ear. The eyebrows might be absent and the child has prominent eyes. And the sole has creases which are ill-defined. The testes may be undescended and the labia majora may be widely separated. So what are some of the physiological handicaps which these children may have? We all know about Jackson Rees who devised the Mapleson circuit. He was actually invited to head the pediatric anesthesia by pediatric surgeon Dr. Fontana, and he developed the Liverpool technique. If you study this Liverpool technique, they give a good dose of IV induction agent, a muscle relaxant, endotracheal intubation, and they ventilate the child till the child is able to, till the surgery is done, and very comfortably they extubate the child. But the problem in this technique is there's no mention of a potent analgesic given. In fact, some of my senior consultants used to tell us when I was doing my postgraduate, कभी किसी बच्चे को सुना है वापस आके कहते हुए कि pain हुआ था, child, and especially a premature child will never feel pain. But now we know about various studies done by Anand KJ and all, that cutaneous nociceptor is developed by 20 weeks of gestational age. The pain pathway is developed by 26 weeks. A fetus of 26 weeks may demonstrate a flexion withdrawal reflex in response to pain stimulation, which indicates that the spinal cord neural connections are present. The descending inhibitory pathways are immature, hence the patient will feel greater pain. So most of these children may also land up into intraventricular or periventricular hemorrhage, depending upon the inversely proportional to their gestational age. And it could be because of the decreased vitamin K or increased capillary fragility in low birth weight babies, hypotension or fluctuating blood pressures, and the use of hypotonic infusions or aggressive volume expansions. Now, because of the open fontanelle, cerebral perfusion pressure varies in accordance with the blood pressure. The lower limit of the autoregulation in infants that's more than 6 months is not reached till the blood pressure has decreased by 40%. And in younger infant, it occurs when mean arterial pressure decreases 21% from the baseline. Now, ischemia due to hypotension damages the watershed areas between the major cerebral blood vessels, and this is especially crucial immediately after the anesthetic induction prior to surgical stimulation. So it is important that we maintain the mean arterial pressure within the limits of the cerebral autoregulation. In the respiratory system, a child of less than 26 weeks, the cuboidal alveolar lining has just begun. In a child between 28 to 36 weeks, the terminal air sacs and the capillaries have begun developing, and 36 weeks of gestation to 18 months, the alveolar phase takes place. The resuscitation is actually difficult at birth because of the type 2 pneumocytes, which are identified between 22 to 26 weeks, but the surfactant becomes prominent only after 34 weeks. The premature babies have a large dead space and a tight volume ratio, and they have diaphragmatic breathing. Hence, they are more fatigable and they are periodic apneas. So let's see what happens. If a very low birth weight infant, he requires ventilation and oxygen supplementation for prolonged periods. It may lead to development of bronchopulmonary dysplasia, which increases after the exposure of more than 28 days. If the child develops bronchopulmonary dysplasia, the oxygen requirement increases, the lung compliance decreases, there's a reversible airway obstruction and increased susceptibility to infections and bronchiolitis. If the child has been intubated for a very long time, tracheomalacia and stenosis may take place. These children, as you know, are obligate nasal breathers, and nasal obstruction is very common. Because of the large tongue, collapsible airway tissue, there's a tendency to airway obstruction. The high oxygen consumption is required to meet the high metabolic demand, and this is met by high respiratory rate. The diaphragm is poorly developed with only type 1 fibers, and this is mechanically suboptimal thorax and is easily respiratory fatigue. The functional residual capacity is less than the closing capacity, and then they are deep dependent and prone to rapid saturation. These premature babies are more prone for apnea, and apnea is pathological if it is for more than 20 seconds, or if it is less than 20 seconds but associated with bradycardia, cyanosis, pallor, or hypotonia. And the incidence is as high as 25% in low birth weight premature babies. We know that most of these children may have hyaline membrane diseases, which has an onset within 6 hours and peaks around 2 to 3 days and starts retraction after 72 hours. The child may be tachypneic, has retractions, grunting, and may have oxygen desaturation. Intratracheal surfactants can be given in children less than 28 weeks. A second dose can be repeated 12 hours later, and third dose if the child is ventilated. Yoon and others in 1999 discovered that chorioamnionitis develops in 92% of the placenta who develop bronchopulmonary dysplasia, and interleukins can be discovered in the amniotic fluid within 5 days of delivery. So bronchopulmonary dysplasia and mechanical ventilation, it has been observed that there is an influx of granulocytes into the alveoli of the preterm babies, even if they have been mechanically ventilated as soon as 1 hour of delivery. In the cardiovascular system, we all know that they have the patent ductus arteriosus closes around 10 days to 2 weeks, but it may reopen whenever the pulmonary artery pressure rises because of hypoxemia, hypercarbia, acidosis, or RDS. And the cardiac myocyte in a premature baby may be there because of the poor contractile force and poor compliance. The parasympathetic system is predominant, which is leading to bradycardia with stimulation. The hypoxia, we all know, is a potent pulmonary vasoconstrictor, which causes a rise in pulmonary vascular resistance, which leads to right to left shunting and exacerbation of hypoxia and acidosis. We all know that heart rate depends on the cardiac output depends on 2 factors, the heart rate and the stroke volume. But in children, it is the cardiac output is totally dependent on the heart rate. Now, in case if there's a bradycardia, then the cardiac output is also decreased. Whereas if there is a tachycardia, this limits the diastolic filling and stroke volume. So the heart rate which has to be maintained is around 120 to 180 beats per minute after we optimize the volume status of the child. The mean arterial pressure should not be allowed to drop below the infant's gestational age in weeks. So if the child is around 28 weeks, the MAP should not be less than 28, or an absolute mean arterial pressure of 30 millimeter of mercury should be kept. In case if the child has an indwelling venous or arterial catheters, we have to be careful about the thromboembolic complications, and repeated sampling may even lead to iatrogenic anemia. The child may be subjected to regurgitation, aspiration because of incompetent cardiovascular esophageal junction. These children have chronic cough and they might be asthmatic. The drug doses have to be very carefully selected and managed because of their decreased hepatic clearance, because of the P450 isoenzymes, which reach approximately the adult levels by 44 weeks. Necrotizing enterocolitis is very common in preterm babies weighing less than 2.5 kgs. These infants may be acidotic, hypoxic, hypothermic, shock, and may require surgery for bowel perforation. We all know that these children have reduced or absent subcutaneous fat or brown fat, and these may lead to loss of body temperature and leading to cardiovascular stress and hypothermia, and which may also result in delay in emergence from anesthesia because the drugs are metabolized very slowly. The renal functions may be impaired, which may lead to drug excretion delay, and finally, the child may take a longer time to emerge out. A lot has been said about fluids and electrolyte in today's seminars. So I'll just briefly touch about it, that there is an apparent increase in the volume of distribution. So the loading dose of the drugs need to be increased. And the reduced binding to albumin and acid glycoprotein leads to increased free drug concentration. The child has an impaired urine concentrating ability, and they're more prone for dehydration, hyponatremia, and hypocalcemia. The hepatic glycogen stores are developed in the last few weeks, and there is an underdeveloped gluconeogenesis. So these children have a they're very prone to developing hypoglycemia. So starvation should be avoided as much as possible. Now, there may be the levels of most of the pro and anticoagulant proteins are low, and this may lead to prolongation of the lab tests such as prothrombin and ABTT. So surgical neonates and preterms are at a greater risk of bleeding due to low levels of procoagulants and may need routine administration of vitamin K. Because of the low levels of procoagulants, these may have a wide normal range of prothrombin time. So agar aapka prothrombin time kam bhi aata hai, that does not mean that the child will have a tendency to bleed or you need to correct it immediately. The term baby has a hemoglobin of 18 to 20 grams per deciliter. In prematurity, the hemoglobin levels are 13 to 15 grams per deciliter, 70 to 80% of which is hemoglobin F, which has a limited ability to release oxygen. Term baby isko compensate karte because of the relatively high blood volume, hemoglobin concentration, and cardiac output compensation. But this compensation is very less in preterm babies. So we target the hematocrit to be about 40 to 45%. Now, these are the premature babies' complication according to the gestational age. Like for the 35 to 37 week, we have delay in establishing full feeds, hyperbilirubinemia may be present. But from 30 to 34 weeks, along with these problems, we also have pneumothorax, we can have chronic lung disease, new BPD, temperature instability, hypoglycemia, and hypocalcemia. In 27 to 29 weeks, along with all these things, the child also has a fragile skin, absent subcutaneous tissue, transcutaneous fluid loss, and perioperative apnea. Less than 26 weeks, we know it is a struggle to survive. So how do you prepare? First, you have a clear discussion with the parents. Take them into confidence. Take a proper consent. Tell them about the ventilatory support which might be required, any untoward effects which may take place during the surgery. Note down the gestational age and the current age of the child. What is the weight of the child? Any perinatal history has to be taken in great details, like the EBGAR scores, birth asphyxia, meconium aspiration, septicemia. If the child is on ventilator, what is the requirement of the oxygen therapy? Any hypoglycemic episodes or any seizure episodes. Document any evidence of congenital heart disease or murmur, and administer intramuscular vitamin K if required. Cross-match the blood if you expect the blood loss to be more than 10%. That is, for a 1 kg baby, it could be 9 ml. Serum electrolytes, glucose levels should be hourly monitored, and the replacement should be given. Period of starvation to be calculated for fluid deficit. TPN, if the child has been given TPN for fluids or glucose or electrolyte imbalance, that has to be documented. And pre-medication of atropine may be given to prevent the transient bradycardia. A closed loop communication is a must with the surgeon. Try to discover if there is any sign of respiration or respiratory difficulty or dehydration. Is the airway patent? Or if the child is on the ventilator, please note the ventilator settings. Get a fresh ABG and chest X-ray to verify the tube position and the oxygen levels in the body. Electrolyte supply, if the child is on receiving IV fluids via the access devices like the infusion devices, see that during the transport, they are functioning properly, the electrical supply is there, and the IV fluids are, the patency of the IV and arterial access devices is there. Agar aapko lagta hai ki IV fluids are not adequate or the IV line is not adequate, you might plan to take a central vascular access after induction. And all infusion and rates should be noted. In the OT, you need to have extra personnel. You need to have somebody who is experienced in the operating department or for the anesthetist. Pressure controlled ventilation is given for delivering small tidal volume with PEEP, but I generally prefer to do a hand ventilation while Mapleson F circuit. And I generally do it for short procedures. In case of long procedures, then we have to manage it. Avoid to ventilate poorly compliant lungs with excessive pressure. High inflation pressure will cause transient systemic hypotension and residual pulmonary hypertension because the reversal of fetal circulation and right to left shunting. Moderate concentration of volatile agents can be used to minimize the increase in peripheral vascular resistance. All the equipment should be there, your face mask, your oropharyngeal and nasopharyngeal airways, your laryngoscope, and the tubes of the correct size should be there. The OT has to be prepared well in advance. The minimum ambient temperature should be around 27 degrees Celsius. There should be effective warming devices like mattresses, air blankets, humidified inspired gases. The fluids, the blood and the blood products and irrigation fluid needs to be warmed. In case if there is a 360 degree axis of the child is required by the surgeon, then remove the head and the foot ends, and intraesophageal temperature using a combined stethoscope and temperature probe can be used. For the induction, if an IV axis is there, if the IV axis is not there, sorry, then you can have a high cardiac output and respiratory rate is increased, and enhanced alveolar ventilation will cause a rapid induction. The MAC needs to be reduced in preterms and it peaks around 1 to 6 months. The sevoflurane above 6% can cause apnea, so we maintain the normal range of sevoflurane around 2 to 3%. So in case if the IV axis is there, you can use ketamine 2 milligram per kg or thiopentone 3 to 4. Propofol is occasionally used. The use of RSI is generally controversial and it is very rarely used. The ETI endotracheal intubation can be carried out after administration of atracurium, fentanyl and sufentanil, which makes for a smooth and intubation. Some anesthetists, they also smear the laryngeal inlet and epiglottis with lidocaine gel using the operator's little finger, and which may facilitate an awake loop or a quick awake intubation. After you've intubated the child, please check for the air entry and also note the depth of the tube insertion. Some of the anesthetists, pediatric anesthetists, they generally use supraglottic airway devices also. A lot has been said about the fluid in today's seminar. I'll just like to stress on certain points that meticulously de-air the lines and prepare the saline flush. The normal rate of infusion of 100 ml per kg in 24 hours and should contain dextrose. The doses should always be pre-calculated. Please do not keep the stock syringes. Take only 1 ml or 2 ml syringes containing the appropriate amount of drugs available, and so the overdosing of the drugs can also be avoided. Record the fluid volume which is given with the drugs, and double check your doses, especially if you are giving uraxyl opioids. The third space losses are also often difficult to estimate. So please, your clinical monitoring at this point is very important, like monitoring tachycardias, diminished heart sounds, hypertension. You can keep a watch on the arterial tracings of the blood pressure and the pulse oximeter. The urine output is very difficult to measure because it's just 0.5 to 2 ml per kg per hour. The pack cells can be given in the dose of desired. What is your desired increment in hemoglobin? Suppose you want to increase the hemoglobin by 2 grams per deciliter, multiplied with the weight, which is 2 kg, suppose, and 3 multiplied by 3. And platelets in fresh frozen plasma is given in the dose of 10 to 20 ml per kg, and cryoprecipitates as 5 to 10 ml per kg. Now, as Shakespeare said, to be or not to be, that is the question. To extubate these children or not to extubate these children is a question. So it depends mainly upon what was the preoperative status of the child, what was the type of surgery performed. Always extubate the child when the child is fully awake and can manage adequate tidal volume without any help. These children are prone for apnea in the first 12 hours and can continue even after 48 to 72 hours. So they need to be monitored for at least 12 hours. And in case if there's one episode or any episode of apneic period, then for further 12 hours. Now, what is the dose of acetaminophen which can be given? In infants of the age group from 28 to 32, we can give 7.5 milligram 8 hourly. From 33 to 36 weeks, we can give 6 hourly. And 10 to 15 milligram 6 hourly can be given in children more than 37 weeks, sorry. Anatomy of the spinal cord is very important in case if you're planning to give a regional anesthesia, that these children only have a one primary anterior curvature. The lumbar and the cervical lordosis is absent. So basically the spine is like a straight spine. And this disposes to high spinal with small changes in position. Agar aapne bachche ka pair bhi uthaya to place a diathermic pad, now this may lead to the high spinal effect. So some prefer a sitting position. Most of us prefer a lateral position. So that way the airway is kept patent. And in case if you're giving a sitting position, keep the head extended to prevent the airway obstruction. A 45-degree head up tilt gives better result and fewer bloody taps. So these are the drug doses. Most of the drug, mostly we use bupivacaine. in the dose of 0.6 to 1 milligram per kg, which is roughly 2 to 3 times the adult requirement. The hyperbaric bupivacaine can be used, or isobaric can be used with or without epinephrine. If you're using any kind of additives like clonidine, fentanyl, or neostigmine, these are the children here then becomes very prone for sedation and respiratory efforts. The epidural in a birth baby is around 6 millimeter from the skin, and it increases to 10 to 12 millimeter at 1 year. But in a premature, we take it as 1 millimeter per kg. So in an ex-premature baby, if he's coming for surgery, general anesthesia is gestational age is the most important characteristic in identifying the risk. And recommendations for the risk-free period is 44 to 60 weeks due to inconsistencies in the studies. Some of the anesthetists have also recommended the use of caffeine, which causes the stimulation of the central respiratory center, decreases the carbon dioxide threshold, and increases the response to hypercapnia. The dose of caffeine, which has been recommended by Wellborn and their colleagues, is 10 milligram per kg. And they say that this reduces the incidence of apneas, but these infants are still at the risk from effects of intubation and ventilation. So for the post-operative monitoring, they should always be, if the child has a post-conceptional age less than 44 to 46 weeks, they should be undergo overnight admission and apnea monitoring. If 60 weeks or more after post-conceptional age is coming, then it is 12 hours of apnea monitoring. But this depends upon your center where you're working. So there are some very important studies which have taken place in past few years. One of the most important studies which I have found was about gas. That is, it is an international, which was done in 28 countries, multicentric randomized controlled trial, where the children were divided into two groups, one which received general anesthesia and the other group which received spinal, in which spinal was given with bupivacaine, and caudal was also given with 2.5 milligram per kg of bupivacaine. All these children were born at a gestational age of more than 26 weeks, and post-conceptual age was up to 60 weeks. And in this, there were 363 awake regional anesthesia and 359 general anesthesia. And they discovered there was no evidence that less than 1 hour of sevoflurane anesthesia increases the risk of adverse neurodevelopmental outcome at 2 years of age compared with the awake regional groups. And early apneas were slightly more common than the general anesthesia. In a Cochrane review by Jones et al., which was undertaken to determine if the regional anesthesia reduces post-operative apnea in children of 60 weeks of gestational age, they discovered that acetaminophen or acetaminophen should be utilized to reduce the opioid doses. The subarachnoid block alone has been used for inguinal herniatomy, but then this is associated with significant failure rate. And agar bilateral surgery here, then the subarachnoid block may be of a disadvantage. So it can be supplemented by giving a caudal injection of bupivacaine with 0.25% or 1 in 2 lakh epinephrine to produce anesthesia lasting for at least 2 hours. And there is no evidence, or there is insufficient evidence to support the routine use of spinal anesthesia for herniatomy. And the use of newer volatile agents with caudal analgesia can be equally beneficial. The spinal anesthesia without sedation reduces post-operative apnea by 47% as compared to general anesthesia. In another study which was done by Kramer, they studied 18 infants less than 51 years of 51 years of gestational age, post-conceptional age, but this study is not very relevant because of the small sample size they have. Another study which was done by Williams, they observed the post-operative recovery after inguinal herniatomy in ex-premature infants, comparing sevoflurane, and they said that spinals are worthwhile only if they are given by an experienced operator. If we provide a less stressful experience with general anesthesia and have a good post-operative monitoring, even GA is a very safe option. Another study which was done by Andreas, they say that the post-op apnea is rare with light general anesthesia using desflurane or sevoflurane combined with the caudal anesthesia. A large multicentric study, which is called the PANDA study, that is the pediatric anesthesia neurodevelopmental assessment. This was compared in 105 siblings, and this cohort study was conducted at multi-scale ambidirectional trial at various centers. And the outcome was their outcome was to measure the neurodevelopmental effects of general anesthesia during inguinal hernia repair in children less than 36 months of age. So there was a specific assessment scale. Pain control was also standardized in all the children, and they discovered that there was no difference in the IQ levels in later childhood. So the take-home message is to anesthetizing a preterm neonate requires constant vigilance, rapid recognition of events and trends, and swift interventions. The risk factors of apnea include a low gestational age, prior history of apnea, post-conceptional age less than 44 weeks, anemia, concurrent cardiorespiratory diseases, necrotizing colitis, and sedatives and painkillers. High-risk patients and PCA less than 50 to 60 weeks need monitoring, and caffeine has shown to be beneficial but still inconclusive. There is no conclusive evidence that regional is superior to general anesthesia in ex-preterm undergoing inguinal herniorrhaphy. The regional techniques have been shown to have a lower incidence of apnea, but any combination of sedatives with the techniques put them at an equivalent or higher risk of apnea as compared to general anesthesia. The success of a regional technique is operator dependent, and caudal anesthesia offers advantage of higher success rate. However, large studies are needed to prove. So not everyone is a preemie anesthesiologist. You have to be special. God just picks up those who are destined to witness a miracle. Thank you so much.
Amazing talk, Dr. Parul. And as usual, you were superb in the talk. And if we go into the discussion part of it, there is only one question is that, have you ever experienced caffeine for purpose of post-operative anesthesia?
Right now, no. I have not experienced or I have not given caffeine, but we have continued with the post-operative ventilation, and we wait till the child has developed, tidal volume, adequate tidal volume, and only then we extubate the child. Caffeine I have not given.
Just one comment I would like to give. Can I?
Please,
ma'am, please.
Yeah,
please.
just that, awake intubation, even if you're putting lignocaine, around the epiglottis, I think it is not justified, even if it is a, small preterm neonate. And I feel that if there is no need, I think one should never go for an awake intubation. That is,
I agree with you, ma'am.
That is
Totally,
one
I
thing.
agree
I
with
think
you.
we should not do it at all.
Ma'am, it is not only it is unethical, it is very inhuman.
It's very inhuman, yes.
It's very inhuman. What we prefer to do is we take it to the sevoflurane incremental doses, and once the apnea is there, then we try to intubate it, and then we give a small dose of fentanyl or an analgesic, whichever we are using.
And the second thing which I wanted to say was, at least in those institutes who have piston-based ventilators, which can give minimal tidal volume, like less than 2 ml, 2 ml and above. So those people should use the ventilator even for these preterm babies. If you're using a pressure control ventilation instead of hand ventilation, it is definitely more superior.
Yeah.
So I feel if you have good anesthesia workstations, then you must go for a proper piston-based ventilator. There should be no problem at all. That's again my other view about ventilating on a JR circuit versus using a ventilator.
Very well
Fully
said,
agree
ma'am.
with you, madam. Madam, I'm not promoting any particular ventilator company, but there is a firm by the name of Nidec. Nidec has got a very good system that you can regulate the pressure as well as the volume at such a rate that you can go to a minimal level of 2 ml per kg body weight as well. And they've got a shifting ventilator of that as well. We have transported a few
Draeger,
patients.
yeah. Draeger has got it.
Any questions by the audience or any point of discussion?
Can I just make a point?
Sure, sir.
I'll just make a point. Dr. Parul, that was an excellent talk. Now there's a lot of
thank you, sir.
Lot of thought process about the long-term neurocognitive implications, neurocognitive dysfunctions, and lots of studies are now coming out. As of now, hopefully, short surgeries, less than 2 hours, or less than 2 cases is quite safe. But premature babies likely to undergo multiple surgeries, I think at the back of our mind, we need to keep the thought that there might be long-term neurocognitive effects.
Yes, sir.
and we may need to address that as a major issue because our anesthetic technique may be affecting it, as later studies may bring out.
What is the what kind of sedation do you use, Dr. Parul, for purpose of post-operative this thing, as well as intraoperatively, like to maintain it?
During surgery?
During surgery as well as post-operative. What is your experience and comparative studies with regarding sufentanil and fentanyl? Or have you ever used a target controlled infusion pumps regarding
No,
this?
we don't have the target control infusion pump, so
Okay.
I don't have
Okay.
much experience about it.
Right.
For
Right.
the
Right.
intraoperative period, we use a combination of muscle relaxant, analgesic, and inhalation, what everybody I think uses. Most of us use a sevoflurane.
Right. Right. Recently, actually, there is a paper in which in the pediatric age group there is a higher use of target controlled infusion pumps, which are being used because of the significance of KEO, as we know that. So that has reduced the volume of the drug being given as well as the dose of the drug being given.
I prefer using a combination of caudal and general anesthesia wherever regional is
Absolutely
possible.
true. Till now, most of the people we are
Most of us, we
excellent
use
we
epidural or a
this
caudal
only.
with a general anesthesia.
Exactly. Caudal epidural catheters for pain relief as well as further proceedings with the general anesthesia.
Precisely.
Right.
Also, in children, we maintain a higher MAC.
Yes,
exactly.
As against an adult. What about
Yes.
a premature?
Ma'am, around for the premature, it is around 40 to 60% of the term babies, the MAC values.
Any other questions? Back to Dr. Vishal.
Thank you, everyone.
Very
Thank
well.
you.
Very
Thank you
well
so much,
explained,
Dr. Parul.
Pavel. Very well.
Excellent presentation.
Thank
and
you so
very
much,
well
ma'am.
covered. It is always a pleasure to have you.
Thank you.
I'm extremely sorry. There's a question. What is your experience about spinal anesthesia in preterm?
Just given spinal in not preterm, but in neonates. At term babies, I have given. So that is, I have experience with term babies. Preterm, I think we've been very traditional in our work schedules, and we prefer using epidural, but spinal we have avoided in preterms. But for terms, yes, in our center we are giving.
Okay. Thank you so much. Thank you. Over to you, Dr. Vishal.
Thank you very much. And moving on, next we move on to the next topic, that is anesthesia and laparoscopic surgery by Dr. Ashok Kumar from Patna. And the session would be chaired by Dr. Nivedita Pani ma'am, Dr. Rekha Das ma'am, and Dr. Vijay Lakshmi. Dr. Nivedita Pani is, she needs no introduction. Madam is GC member and of RCCP. Dr. Rekha Das is also GC member of RCC. And so is the Dr. Vijay Lakshmi ma'am, GC member RCCP. I would like to call upon Dr. Nivedita Pani ma'am to welcome and introduce Dr. Ashok Kumar sir.
Thank you, sir. First of all, happy RSSAP Foundation Day to all. It is really proud to be a part of RSSAP and learning from all the wonderful speakers of the day. And congratulations to all the speakers. Long live RSSAP. Let me first introduce Dr. Ashok Kumar. He is the professor and head of the Department of Anesthesiology from Nalanda Medical College, Patna. He has got many scientific presentations as a guest speaker and CME lectures, and he has got a lot of research publication. He is also a MD and DNB examiner in many Indian institutes and universities. He is also an assessor of the NMC, and he is also national faculty and life-saving anesthesia skill for EMOC training. And he very frequently comes as an examiner to our state also. Sir, welcome to the August evening and for your nice deliberations. Thank you, sir. Dr. Ashok Kumar, sir.
Please share your screen, sir, and unmute yourself, sir. You need to unmute yourself, sir.
Sir is on the line.
Yes, sir, ma'am. We can see, sir, there. Yes, sir. You are unmute, sir. Please share your screen, sir. Thank you.
Okay, I'm trying for that.
I request all the listeners, please, whatever question you want to say, please write in the chat box. At the end of the session, sir will give the answer.
And also to mute
Yes,
themselves, you know, because
yes.
we are hearing few, you know, not.
पहला फर्स्ट पेज करके अच्छा तो बैठ यहाँ छोड़ो ना हो गया है हेलो हेलो
It is visible, sir. Please go ahead, sir. It is visible.
I am audible to you.
Yes, sir. Yes, sir. Please, you are audible, sir. Please go ahead.
So किसको लगा लीजिए सर for a moment. अब आवाज आ रहा है. Are you listening me, sir? Hello.
Yes, sir. Yes, sir. You are audible, sir.
Audible, sir.
Okay.
Please go ahead.
Thank you, sir. Good evening, everybody, and congratulations for RSCP Foundation Day. It is my pleasure to be among my senior colleagues like Dr. Sharma sir, Dr. Tej Kaul sir, Dr. Rakesh Garg sir, Dr. Naveen Malhotra ji, and other my colleagues, Dr. Nani, Dr. Anjali, Dr. Anil, and not able to name all of them. Thank you, the organizers, for giving this opportunity so that I could be able to meet all of my colleagues in this forum. So my today's topic, anesthesia for laparoscopic surgeries. Laparoscopy has revolutionized the field of surgery, and any surgical remedy, if option given to a patient, he will always like to prefer Durban wala surgery because it has a lot of benefits. And we know that every benefit has to pay some cost, so it has got some demerits also. In this discussion, we shall be taking care of all those aspects from introduction to summary and conclusion. First of all, what is laparoscopy? Laparoscopy is constituted by two words, laparo plus scopy. Laparo means flank between ribs and hips, and scopy means examination and or visualization. So, laparoscopic surgery is surgical procedures done under vision in minimal invasive form. So performance of laparoscopic surgical procedure requires some intra-abdominal space for proper visualization of the target organs and manipulation of the laparoscopic instruments so that surgery can be performed. And this is the difference between the conventional surgery and laparoscopic surgery. The space is created by creating a pneumoperitoneum by intraperitoneal insufflation of carbon dioxide, as well as optimal positioning of the patients for optimal space and visualization. This special technique done for laparoscopic surgery had a lot of interactions with other factors like patient's physical conditions and their important coexisting morbidity, altered physiology by space creating maneuvers, effects of selected surgical procedures as the surgical procedures vary in quantity and quality a lot, and effects of anesthetic drugs and technique which we anesthetists use to upon the. So all these factors combined together a specialized technique for laparoscopy used to increase morbidity and mortality to compromised patient, and at least it is supposed to increase. So by tailoring anesthetic and surgical techniques, one can reduce these ill effects. Patients' physical condition and important comorbidity are age of the patient, higher the age, greater the risk, severe ischemic and valvular heart disease, significant renal dysfunction, and stage respiratory disease, pre-existing rise in intracranial pressure, severe uncorrected hypovolemia, non-right to left cardiac shunts, patent foramen ovale, and a lot of others. Maneuvers performed for laparoscopic surgery are two, as just enumerated earlier, that is creation of pneumoperitoneum by insufflation of carbon dioxide, and other is optimal positioning of the patients. This pneumoperitoneum has got different effects, important ones, pressure effects in the form of raised intra-abdominal pressure, pharmacological effects due to carbon dioxide as producing hypercarbia, and physical effects. Optimal positioning of the patient is done in two forms, that is Trendelenburg position, that is inclination of the patient head towards head down, and reverse Trendelenburg position. Both these positions acts upon by its gravitational effect upon diaphragm as well as upon venous return. The pressure effects include pressure on abdominal contents, pressure over or splinting of diaphragm, tissue plane splitting, decrease in temperature, and stress hormone release. Pressure effects. This can be known in the form of different pressures that we use or can produce. Usually a pressure of 10 to 12 millimeter of Hg is used for this laparoscopic surgery, and this has got minimal hemodynamic effects. But sometimes we use to raise the pressure for visualization of the or better visualization of the organs, and up to 12 to 15 millimeter of mercury you can use safely, but this place there is increased peritoneal stretching, increase of vagal tone, bradycardia, certain arrhythmias, and some circulatory instability is there. The intra-abdominal pressure rises more than 15 millimeter of mercury. There is vascular compression, increased vascular resistance, and increased mean arterial pressure. There is peripheral pooling of blood, decreased venous return with decreased cardiac output. The decrease is nearly 25 to 35%, and this may lead to hypotension. Furthermore, there is a rise in central venous pressure up to 8 mmHg higher. When the intra-abdominal pressure is greater than 20 millimeter of mercury, there is decreased splanchnic perfusion, which their organ dysfunction. Renal perfusion is decreased to a lot, and so urine output is decreased. Hepatic perfusion is also decreased, and portal flow is decreased by 60%. There is increased lower esophageal sphincter tone. This might be beneficial at that time by reducing regurgitation and acid aspiration syndrome, but at the cost of ill perfusion of the organs. Pressure effects on diaphragm. Diaphragm is displaced cephalad, and this causes a rise in intrathoracic pressure, opening of umbilical channels, and increased intrathoracic pressure will also cause increased intracranial pressure and increased intraocular pressures. Cephalad diaphragmatic displacement further reduces thoracopulmonary compliance by 25%. It reduces different lung volumes like tidal volume, minute ventilation volume, functional residue capacity, and due to mechanical pressure, it can cause collapse and atelectasis with shunting and hypoxemia. The movement of endotracheal tube may be to one bronchi, leading to endobronchial intubation or one lung anesthesia. Pressure effects on diaphragm further. The rise in intrathoracic pressure will increase pulmonary and positive pressure ventilation in this situation will cause barotrauma and uneven ventilation, perfusion mismatch, hypoxia, and hypercardia as well as insuflating carbon dioxide. Opening of umbilical channels can lead to pneumothorax, pneumomediastinum, pneumopericardium, and rise in intracranial pressure and ocular pressure already mentioned. Tissue plane splitting is also there due to high pressure. If due to some rent or some split in tissue, the carbon dioxide under high pressure enters into the tissue, it can lead to subcutaneous emphysema, gas embolism, and thromboembolism. There can be decrease in temperature because exsufflated gas under pressure lead to minus 0.3 degrees centigrade decrease in temperature by every 50 ml exsufflation of carbon dioxide. And further temperature down might be due to fluid irrigation. Further pressure effect is increase in stress hormones that in the form of release of catecholamines, angiotensins, vasopressin, cortisol, ACTH, insulin, glucagon, etc. Pharmacological effect of this pneumoperitoneum is hypercarbia because carbon dioxide, a physiological gas, is used for creation of pneumoperitoneum, and under pressure it rises to about 15 to 25%, and a plateau is achieved within 15 to 30 minutes. This hypercarbia is due to a rapid carbon dioxide absorption from the blood vessels, but as the intraabdominal pressure will rise, its absorption will be reduced by that way. Any disproportionate rise of carbon dioxide suggests for some cardiorespiratory compromise or subcutaneous carbon dioxide emphysema, from where carbon dioxide is abnormally absorbed. Pharmacological effects further is increased sympathetic activity due to hypercarbia that will lead to tachycardia, increased systemic vascular resistance, rise in blood pressure, arrhythmias, etc. And there is further rise of arginine vasopressin nearly 5 times. And due to exhalation of carbon dioxide in alveoli, there might be fall in partial pressure of oxygen in alveoli, and there are chances of hypoxemia there. We practically find this raising the oxygen concentration with normal anesthetic technique is not there, and we have to increase always the FiO2 during laparoscopic surgery. As carbon dioxide can produce respiratory acidosis, there might be dysrhythmia by this also. अच्छा, less okay, physical effects are there, and these physical effects are less in carbon dioxide pneumoperitoneum in comparison to other gases used for pneumoperitoneum. And the physical effects are air trapping in the form of subcutaneous emphysema, pneumothorax, pneumopericardium, and postoperative shoulder tip pain. And there might be venous gas embolism also already discussed. Positioning of the patient, optimal positioning of the patient can be Trendelenburg position or reverse Trendelenburg position depending upon the site of operation. As for example, if operations is to be performed in pelvic cavity, the patient is inclined to head-down position, that is Trendelenburg position, and for laparoscopic cholecystectomy, we place the patient in reverse Trendelenburg position so that under the gravitational effect, viscera are pulled down and space is increased. But it has got effect, gravitational effect upon diaphragm as well as venous return. This can be summarized in this. Inclination usually done for 15 degree and diaphragm is moved cephalad in Trendelenburg position, but caudate in reverse Trendelenburg position. In cephalad movement of the diaphragm, there is respiratory embarrassment, while during caudate movement of diaphragm, the respiratory embarrassment will not be there. Similarly, regarding venous return, Trendelenburg position favors venous return under the influence of gravity, while reverse Trendelenburg position opposes venous return and may lead to decreased cardiac output and hypotension. This table is a summary of different effects of pneumoperitoneum and positioning of the patient as well as carbon dioxide effect. So in this table, we can find that in any situation, sometimes some factor will support one parameter and at the same time will oppose the opposed by the another factor. So final effect will be after being sum up, and that will be observed clinically at the time of operation or anesthetic administration. Control of these changes, what has happened due to creation of pneumoperitoneum as well as positioning. So hemodynamic changes can be controlled by pre-pneumoperitoneum fluid load, intravenous nitroglycerin, nicardipine, dobutamine. Nicardipine is preferred, and ventilatory problems can be minimized by giving general anesthesia, with general anesthesia and intermittent positive pressure ventilation. Ventilation with high respiratory rate and a smaller tidal volume, because as carbon dioxide is to be washed out, so we need hyperventilation here, and increasing tidal volume for hyperventilation may cause barotrauma and polytrauma. So high rate, a smaller tidal volume ventilation is beneficial. Now anesthesia for laparoscopic surgery. A standard anesthetic technique is to be modified to some extent due to specialized maneuvers performed as well as certain associated coexisting conditions. In cardiac patients, laparoscopic risk-benefit balance is to be assessed before choosing If we find the risk more, then it is better to undergo conventional open procedure. If left ventricular ejection fraction of a patient is less than 30%, this is very precarious for hemodynamics, and he needs intraoperative monitoring, arterial line placement, transesophageal echocardiography, pulmonary artery catheter, continuous 60-segment analysis, and he should undergo for general laparotomy or gasless laparotomy if available. Of course, the data regarding gasless laparoscopy is not much available. And in this patient, pre-medication should be given so that those are rapidly lost and recovery is fast. Regarding intraoperative management, operation for better outcome, operation should be performed by experienced surgeon. Insufflation should be slow, and intra-abdominal pressure should be kept minimum. Pre-pneumoperitoneum preload must be given. And if the patient is to be tilted up, down, or side, that should be done after insufflation. Anesthesia should be supplemented by fentanyl or vasodilating anesthetics and drugs as mentioned, and cardiotonic agents as required. Post-operative, regarding post-operative care, pain, nausea, and vomiting and pulmonary dysfunction is troublesome in laparoscopic surgery. For pain, opioid remains an important component of the anesthesia technique, pain management technique. A pre-operative multimodal analgesic regime will be useful in which a nerve block or nerve squeezing along with NSAID as well as narcotics or other modalities of pain relief are to be used. For nausea and vomiting, prophylactic use of ondansetron and even corticosteroids seems to be beneficial. Oxygen supplementation is needed because due to pneumoperitoneum, it takes some time to get full ventilation. At the same time, diffusion hypoxia will be there because carbon dioxide will be releasing to alveoli in higher rate, and that will be decreasing partial pressure of oxygen in alveoli, leading to diffusion hypoxia, and barotrauma, some form of other problems might cause pulmonary. So oxygen supplementation should be continued at least for 20 to 30 minutes post-operative. Regarding anesthetic techniques, there is no major role in patient outcome because it has been observed that general, regional, or local anesthesia all are safe and satisfactory. But balanced general anesthesia is the best form of anesthesia, a standard technique. Of course, there are some problems regarding local techniques or laparoscopic anesthesia in which pneumoperitoneum creation and patient positioning will pose some problems. So general anesthesia, rotator ventilation, and intermittent positive pressure ventilation is the standard technique in which the carbon dioxide level must be kept between 35 to 40 millimeter of mercury, and minute ventilation should be increased by 15 to 25%. Intra-abdominal pressure should be kept below 15 mmHg, and this should not exceed 20 mmHg. And this can be done by deep plane anesthesia. Anesthesia mask airway spontaneous breathing has been practiced, but this is restricted to low internal pressures and short procedures. Prosil LMA has also been used for this, but the pressure inside the airway should not exceed 30 centimeter. Regarding local and regional anesthesia, local and regional anesthesia requires precise and gentle surgical technique. IV sedation is needed in this that may result into hypoventilation as well as arterial oxygen desaturation. Patients have increased anxiety, pain, and discomfort during organ manipulation. So, regional anesthesia is avoided in complex laparoscopic procedures. In my opinion, general anesthesia is always better to regional anesthesia for laparoscopic procedures. Complications. Complications may be traumatic injuries during intraoperative period, cardiorespiratory compromise during upper abdominal laparoscopy, especially in ASA grade 3-4. Post-operative infection will be also with some significance, and mortality rate has been variously quoted, 1 by 10,000 to 1 by 100,000. Traumatic injuries are sustained during blind trocar insertion, patient positioning, pneumoperitoneum creation, inappropriate site insufflation, surgical duration of a larger surgical duration. Anesthetic technique also might produce trauma. Traumatic situations during surgery used to be bleeding from injured side and visceral injuries. Some of the complications may require laparotomy. Of course, the incidence is very low, 2 to 10 per thousand case, and injuries requiring laparotomy are intestinal injuries. In 30 to 50% of the laparotomy cases required. Vascular complications, 30 to 50%. Burns, 15 to 20%. Despite decrease in death rate, the complications is slightly higher in the most recent surveys. This is probably due to increased complexity of the laparoscopies performed over the past few years. Experience is associated with decreased operational times and rate of minor and moderate complications. Anesthesiologist must maintain a high index of suspicion. High index of suspicion for complications and dealt immediately. Complications like gas embolism, extraperitoneal insufflation, surgical emphysema, pneumothorax, and pneumomediastinum. To summarize, the increasing laparoscopic success due to less surgical trauma, pain, pulmonary dysfunction, hospital stay with quicker recovery has gradually increased its role in complicated surgical procedures. Complication incidences are favorable compared to open surgery. The preference for laparoscopic surgery amongst the public as well as surgeons is increasing day by day, even for the complicated surgical disease with higher ASA grades. General anesthesia with controlled ventilation is the standard technique. Alternative insufflating gases like helium, argon, nitrous oxide, nitrogen do not seem to reduce the hemodynamic changes. The physiological alterations and intraoperative cardiorespiratory disturbances due to carbon dioxide, raised intra-abdominal pressure, and patient positions may be aggravated in compromised and high-risk cardiac patients. posing great challenge to the anesthesiologists. So better understanding of the pathological changes and remedial measures allows for successful anesthetic management of the even compromised patients by optimizing pre-pneumoperitoneal preload as well as vasodilating agents and other agents. So this way, laparoscopic surgery with providing a great benefit to the patients is very essential part of surgical field, and anesthetists have to take care of the patients which are affected more and more by special procedures of pneumoperitoneum and patient position as well as coexisting conditions. Thank you.
Thank you, Dr. Ashok. So that was a good talk, comprehensive talk on anesthetic management in laparoscopic surgery. I would just like to, I don't think there are any questions in the chat box. I think he has covered everything comprehensively. I would just like to add one point post-operatively. There are sometimes patients, if there is a bleed or something, patients usually have a normal blood pressure. So if there is a tachycardia that is persisting in spite of pain relief, then it should raise a suspicion of an unseen or a hidden bleeding somewhere during a laparoscopic procedure, which might likely get hidden during while you are taking out all the brocars and all. That could be little hidden, and so later on the patient can have only tachycardia as the only presenting symptom, which is not responding to any fluid therapy or pain relief or any if you are giving, if there is a need of blood or whatever it is. And another very important thing I would like to say that if it is a prolonged surgery, nowadays even supramajor surgeries are being conducted under laparoscopy, particularly robotics and all. They are all basically they are all laparoscopic surgery. So you have to be very particular about the airway. So post-operative airway management is also a very important criteria that needs to be looked into, in addition to multimodal pain, which everyone is very aware, is quite conscious of. These are the two things: post-operative tachycardia, which might be due to a bleeding that is occurring and probably is being overlooked in a patient who has a normal blood pressure, a normal saturation, no complaints, and a patient who might likely to have a compromised airway post-operatively because of laryngeal edema or because of the opioid. So it is always advisable to extubate your patient when the patient is fully awake, particularly when you are going for a prolonged laparoscopic procedure. So these are two points I just wanted to, because I give a lot of robotic cases for long procedures, and we also do a lot of supramajor oncological surgeries under as laparoscopic procedures and robotics. So these are some complications which we do experience in a daily life. Thank you, and that was a very good
Dr. Rekha. Of course, Dr. Rekha, these are the problems that one take care for laparoscopic surgery, but those are important for even for general surgical procedures which we perform day by day: airway care, oxygenation, or pain care, or bleeding care. We have to take care of all those. Of course, during laparoscopy, that it will be especially cared for.
Sir, I have just a experience of yours. I'm telling nowadays, a lot of people are doing with the supraglottic airway devices. What do you feel that?
No, I have just told that the supraglottic airway device, as we are giving positive airway positive airway pressure against the raised intra-abdominal pressure, so chances of leaking at junction of the mask as well as glottis, there are chances always of leaking and insufficient ventilation. Sometimes there might be aspiration also from that leak. So I would not like to have laparoscopic surgery, just I told. That is possible. We raised only slight. But if you are going to perform a larger surgery, even for laparoscopic cholecystectomy or hysterectomy, it is not proper to use LMA or even Procil LMA. Best way to secure airway endotracheal intubation, gold standard.
Thank you, sir.
Dr. Vijayalakshmi, would you like to add something? And Indrani ma'am.
Pardon?
Yeah.
Actually,
Dr. Vijayalakshmi is also a chairperson, so I am asking her if she would like to add something. And of course, Indrani ma'am is at the helm of affairs. She would also speak something.
Yeah, madam, I think started. Indrani madam I'll follow.
Just that if it is a short duration surgery, less than 4 hours, we are comfortable using supraglottic, second generation supraglottic airway devices, because the pressure it can tolerate almost up to 50 to 60 centimeter water. So I think up for short surgeries up to 4 hours, we are okay with supraglottic airway devices. In fact, most of our lab colis are done with supraglottic airway devices. The surgeons are pretty quick. They just take like 1 to 1.5 hours max, and we are okay with it. Only that if we are dealing with novice, somebody who's learning laparoscopy, or students, or if it is a long surgery, then we always would want to intubate these patients.
Madam, in that situation, in my opinion, there must be some study regarding what is the effect at glottis and mask junction, because if the tolerance of the junction is more than 50 and you are giving that pressure in that situation, because both are separate bodies, one soft tissues and another material. So at the junction, there might be some trauma due to such pressure. So in future, one must study regarding this. What is the effect upon that junction where the mask seals the glottis?
So we are using iGel. So iGel, generally because of its thermoelastic properties, it seals very well. It seals very well. So we don't have a problem on that issue, because the maximum intra-abdominal pressure achieved is only 15 millimeter of mercury. So and our surgeons don't even go that much. They do it at around 12 millimeter mercury. So I can speak for myself that we are comfortable using it.
Of course, the further works are needed upon this. That is possible. This is not rampant. In our institutions, we have got agile, but we are not using that for laparoscopy. But as the advances are going on, further its use might be possible.
Sir, and also, as I said, if you're having a novice learning laparoscopy, we also find it comfortable to intubate the patient, because we don't know how long it's going to go on.
Yeah.
So we also, if it is a learner, if it is a student who's learning, we intubate these patients.
Good evening, sir. Good talk. I too agree with Indrani madam. We use supraglottic airway devices, especially in shorter and even reverse trendline bunk procedures. So that is where it will be more useful. And one more thing I just wanted to add on was the respiratory complications which we had thought about. One of the most common one, which the increased intra-abdominal pressure, which you have stated causes, is atelectasis. So the ventilation strategy, which I would like to just add on one bit, is adding of adequate PEEP at the right time. So it's not only the increase in the rate and the tidal volume adjustment to the CO2, but your PEEP, adding the PEEP at the right time, which would prevent this atelectasis, which is the most common cause for your postoperative pulmonary dysfunctions, where the patient will accumulate CO2 as well as the oxygen desaturation is seen. So especially, as you said, if it's prolonged case, or even a briefcase, you have to add on the P. That is one thing I just wanted to add on.
Madam, in every case where we are using ventilator, we give 4 to 5 centimeter of PEEP. Normally, in every case, without PEEP, one can't work. So, if you suggest to give even more PEEP, I don't know whether you are suggesting to give more than 5 PEEP or what else. Because more than 5 PEEP, we should not give to that extent, because ultimately that continuous PEEP will cause hamper circulation as well as produce trauma. Usually, in every case we give 4 to 5 centimeter of. In females we give 3 to 4, and in males we give 4 to 5 centimeter of PEEP to each and every patient we give.
Yes, in regularly.
That is physiological.
Yes,
physiological.
But in laparoscopic surgeries, we go a little bit higher up than that, say 6 or 7, but making sure that there is no hemodynamic compromise. So that should be
okay. That can be done. That can be done.
That's one. That's what we practice in our place. So that's what I wanted to add on. That was a very good talk.
Nowadays, we are using a 4-case system. So in such cases, we require a little bit of BP on the lower side, like systolic touching 100 or sometimes below, like around between 90 to 100, or a mean arterial pressure of more than 60. So what all drugs can be safely used if we want to permit a deliberate hypotension in laparoscopy by keeping the PEEP at around 7 to 8? Which is, yes, we should always use a PEEP of around 6 to 7 or 7 to 8 without having a hemodynamic compromise. But what all drugs can be used along with that in order to maintain a deliberate hypotension?
Sir, I would like to use combination of drugs, short-acting beta blocker as well as short-acting vasodilators in titrated form. Let others give opinion regarding this also. In my opinion, we are using esmolol along with nitroglycerin.
And in such cases, dexmedetomidine is it a good choice?
Pardon, sir?
Dexmedetomidine, is it a good choice?
Dexmedetomidine.
Dexmedetomidine.
That can be a good choice because it can produce analgesia also, but that is not a controlled one. That is not a agent that can give controlled hypotension to us. Controlled hypotension can be happen by the use of inhalational anesthetic agent as well as combination of beta blocker and vasodilators. Sole use of nitroglycerin is sometimes or many times is associated with tachycardia that compensates for fall of blood pressure. So we have to add short-acting beta blocker esmolol to get the proper result.
Thank you, sir.
Welcome.
Do we have any other questions, ma'am?
Yes.
Dr. Rekha ma'am, Dr. Nivedita ma'am, Dr. Vijayalakshmi.
I think there are no questions in the chat box.
Sure, ma'am. Please go ahead, ma'am.
You can go ahead. No questions, Dr. Vishal. I think we'll hand over the session, end it, I think, with you.
Thank you, sirs and madam, everybody. Nice to meet all of you. Very happy on this platform. Today I could meet a lot of my kith and kin friends. So I'm very happy.
Thank you very much, sir.
नमस्कार सर लोगों को नमस्कार, पॉल साहब को नमस्कार, राकेश जी को नमस्कार, शर्मा सर शायद हैं कि नहीं? हाँ, शर्मा सर को नमस्कार, सब लोगों को नमस्कार।
नमस्कार नमस्कार
नमस्कार
कैसे
सर।
अशोक हाँ।
बहुत अच्छा लगा सर आज, और आशा करता हूँ कि भविष्य में और भी मिलने का मौका मिलेगा।
Yes, sir.
Dr. Indrani ma'am, with your due permission, should we conclude the session, ma'am?
Yes, I think we should wind up the session.
I think it will be better to call it as a CMB than a session. 9 o'clock, 4 hours of continuous education program with good talks by all the speakers, including Dr. Parul, Dr. Ashok, and Dr. Anil.
Sir, you are not audible, sir. You are not audible, sir.
Somewhat audible. I'm saying, Vishal, it's a half day CME.
Yes.
Yes, sir.
It's a half day
Yes, sir.
CME.
Half day CME, sir.
Sure, sir.
Yes.
RTS, congratulations.
Sir,
Thank you, sir.
and
Thank you very much, sir.
excellent discussion, sir. That was again the hallmark of today's CME.
Yes.
Yeah.
The discussion should be the backbone of CME.
Yes, sir. And your lecture, you it was a must for all the PGs to listen to you, sir.
Thank you, sir. Thank you, madam.
And I think the Foundation Day celebration started 2 weeks before, and yesterday there was a excellent simulation-based hemodynamic monitoring workshop in Kolkata 2 weeks before we did it in Mumbai. And what a wonderful, what a great end what a salute to RSACP with today's CME. It was a fantastic session, brainstorming session. Thank you very much to all the speakers.
My special thanks to Dr. Singla, who conveyed me for this opportunity. A special thanks to him.
Thank you very much, sir. Thank you very much, sir.
Thank you very much.
Sir, everything was discussed in detail, and it would be my proud privilege to propose my vote of thanks to our valued and distinguished dignitaries on this platform. I would like to extend my thanks to, first of all, to President Dr. Indrani ma'am for always being the support and giving webinar a wonderful discussion. Thanks to Dr. Tej Kaul sir for joining us, for inspiring us, and sir is always there, and we learn a lot from you, sir. I would also thank our chairpersons who give the valuable critical inputs on the talks delivered today. I would like to thank Dr. Naveen sir, Dr. Sethi sir for constantly pushing to maintain the high standards. Thanks all for such an interactive session. It was a pleasure listening to you all. And a very happy RSCP Foundation Day. It was indeed pleasure listening to all of you. Long live RCCP.
Long live RSACP.
Long live
RSACP. Long live
RSACP. Namaskar.
Good night, everyone.
Namaste.
Sir, namaskar.
Thank you, sir.